So good evening everyone. Good evening, good evening. Yes. Yes. So we are here today to start with our new journey, that is the fellowship in rheumatology. So new journey we have got is the fellowship in rheumatology that we want to do today. Right? Great. So we have done with our nephrology in the same order. In the integrated approach, we are going to start with the rheumatology. Yes. So same approach we want to follow for the rheumatology class also. So these markers, we'll run them down for now. Yes. So I think everybody is okay now, ready to start. Right. So today we are going to do with rheumatology. In rheumatology also, we want to start with the review of the physiology, then the symptom, and then the classification and so on. So let's get started with first step, that is review of the physiology of the immune system. So in rheumatology, the first step we are going to do the review of the immune system physiology. We are going to start with the immune system physiology first. So immune system physiology, mainly it is the immunity. The role of the immunity is to protect our body, against the entry of antigen and pathogens. Against the entry of the antigen and the pathogen is the role of the immune system. Immune system physiology, the main role of immune system is to protect the body against the entry of antigen or pathogen. That is the role of the immune system. Right. So in the immune system, there are two types of immunity. We have got the innate immunity. The immunity broadly divided into two types. The innate immunity, which is a more primitive form, which is a more basic form of the immune system. So big column for the innate immunity, big column, and we have got a small column for the adaptive immunity, small column for the more modern, that is the adaptive immunity we have got here. Is the adaptive immunity. So broadly, we know that there are two types of immunity working in the body. We have got the innate immunity and the adaptive immunity is present in the body. So how does the innate immunity work? The innate immunity consists of 9 components. The innate immunity consists of the 9 components arranged in a very, very well structured manner, even the immune system. The first part, whenever an antigen tries to enter the body, the first line of defense is the physical barrier, that is the anatomical barrier, which protects the body against the entry of antigen into the body. So first level, we have got anatomical barrier. The anatomical barrier consists of the skin, the mucous membrane, etc. The skin, the mucous membrane, etc. consists of the anatomical barrier, which protects us from direct entry of infection into the body. Number 2, to support the anatomical barrier, we have got the PRRs. The PRRs are the pattern recognizing receptors. We have got the pattern recognizing receptors are present in the body. Pattern recognizing receptors are present in the body. These pattern recognizing receptors act as the sensors, act as the alarm system or the sensors of the human body. They act as the sensors of the human body. So whenever they come in contact with a foreign antigen, they trigger an immune response. Hence they are also known as an inflammasome protein. Whenever they come in contact with a foreign antigen, they stimulate or they initiate an immune response. Hence they are also known as inflammasome protein. The examples are the lectins and the hexinases. The lectins, the hexinases, etc. act as the sensors of the human body. So they are like our alarm system. Whenever a foreign body enters into our system, it will trigger or initiate an immune response. We also have the AMPs. The AMPs are the antimicrobial peptides. We have got the AMPs, the antimicrobial peptides. We have got in the body. Antimicrobial peptides we have got in the body. These are small peptides less than 100 amino acid in size. These are small peptides which are less than 100 amino acid in size. Classical example are the lysozymes which are present in the tears and in the saliva. Present in the tears and in the saliva. So our immune system, it is very well structured. Whenever an antigen or a pathogen wants to enter the human body, immediately we are defended by the anatomical barrier, the pattern recognizing receptor and the antimicrobial peptide. Till these three components, what we call them as the non-cellular components of the innate immunity. These are the non-cellular components, non-specific they are, non-cellular components of the innate immunity we have. The first immune cell are the NK cells. NK cells are the natural killer cells. The natural killer cells, I compare them as the watchmen of our body. The NK cells are like the watchmen of our body. So what do the watchmen do usually? The watchmen are usually controlled by the rules of the society, rules of the institute. They look very strong, but usually they lack in the IQ. It is not necessary, no? It is not part of their job profile. Being a watchman requires you to have strength, not brain. Similarly, the NK cell, like the watchman of the body, are the largest WBC in the body, but their function is completely regulated by the interleukin 2, which is secreted by the T cells. The function is completely regulated by the interleukin 2, which is secreted by the T cell. But the NK cell are very important to us because they are the only immune cell. They are the only immune cell with non-MHC restricted action. They are the only immune cell with the non-MHC restricted action. So what is this non-MHC restricted action and why are they essential to our body? Let's understand. So these NK cells, like the watchmen of the body, are the first level of cellular defense. They are the first level of the cellular defense. They are large in size but controlled by the interleukin 2 secreted by the T cell. But they are the only immune cell with non-MHC restricted action. So let's understand what are these MHCs. The MHC are the major histocompatibility complex antigens. MHC are the major histocompatibility complex antigen which is expressed on every cell. They are present on every cell. These MHC class antigen are present on every cell of the body. MHC major histocompatibility complex antigens are present on every cell of the human body. But what do? They act as the identification marker. So what they do? They help the immune system. They help the immunity distinguish between. They help the immunity distinguish between the self and the foreign antigen. The self and the foreign antigen. So basically they act as the identification marker for the immune system. That is important, no? Because the immune system, when it is manifesting in the body, it should not wrongly destroy our own cell. So to identify, the immune system takes the help of MHC antigen. There are three classes of MHC antigen. The class 1 codes for the T cells. The class 2 codes for the monocyte macrophage system. The monocyte macrophage system. And the class 3 codes for the complement cascade. For the complement system. So they act as the identification marker. Identification marker. We are going to get identification marker. We are going to have. But what happens when our own cell, sometime our own cell with age, with infection can develop mutation. Our own cell can become mutated and turn into cancer. But we want our abnormal cell to be removed. But immune system is incapable. Immune system says that I cannot do anything because as long as the cell has got the MHC antigen, I cannot touch them because they are self antigen. They are my own part of the body. But only NK cell can, because of their non-MHC restricted action, the NK cell can clear the mutated and the virus infected cells of the body. They can clear the mutated and virus infected cells of the body, and that is how They play important role in both. They play important role in both the immune as well as the tumor surveillance. Very important. The immune as well as the tumor surveillance, they play an important role in. So NK cells are unique among our immune cells because they can clear the self antigen also when it can be having the problem. So there are three classes of MHC antigen. MHC antigen class 1 codes for the T cell. The class 2 codes for the monocyte macrophage system. And class 3 codes for the complement cascade. But NK cell have got non-MHC restricted action. That is the meaning that it can clear our own abnormal cell, making it important component. But let's look at the story. Once the NK cell, the watchman has caught the robber. The watchman has caught the robber. The watchman has to call the police. The police of the body are the monocyte macrophage system. The monocyte macrophage system. The policemen of the body are the monocyte macrophage system. So why am I comparing them to policemen? What do the policemen do? They come and they arrest the robber. The policemen come and arrest the robber. So we have got here also the monocyte macrophage will engulf the antigen. The monocyte macrophage system will arrest the robber. That means it will engulf the antigen. It will arrest the robber, engulfs the antigen. And if you look at the police, where are they present? Majority of the policemen are in the police station. But some of them are also patrolling sensitive areas. Patrolling sensitive areas. So what is sensitive area in our body? So like policemen, monocyte are also organ specific macrophages are also present. Organ specific macrophages are present which are patrolling the sensitive areas. Which are the sensitive areas in the body for immunity? The routes of infection. They are patrolling the sensitive area and they are the routes of infection. So these are the common site from infection where they can come. Infection can enter direct contact through the skin. Infection can enter through the inhalation into the lungs. Infection can reach the liver through the food that we eat. And the president of the body, the chief minister of the body who requires special patrol is the brain. Is the brain that requires special patrol. So they also have got the special organ specific macrophage system. So I want you to remember immune system is highly complex, but it is very well organized. It's not random arrangement. So it's a stepwise manner when the immunity will get activated. The immune cells, the macrophages in the skin, they are called as the Langerhans cells. In the lungs, they are called as the Clara cells. In the liver, they are called as the Kupffer cells. And in the brain, we have got microglial cells. In the brain we have got microglial cells. We have got. So monocyte macrophage are like the policemen of the body. They arrest the robber and patrol sensitive areas. But after arresting, the robber has to be presented in the court. Who is the one who is going to present the antigen? Dendritic cells. The dendritic cells are called the most potent APC. They are called as the most potent APC, that is antigen presenting cells. We have got the antigen presenting cells are present. Antigen cells for the presenting cells. And then we have got the support of the granulocyte series. So whenever there is, right? So whenever there is granulocyte series is also there. Whenever there is a sudden riot is present, we need acute rapid action force. So acute infection, who comes into the blood? The neutrophil, the basophil and the eosinophil. The neutrophil, the basophil and the eosinophils are going to be the special acute phase cells. So they come when there is an acute inflammation, like a rapid action force. They are like the rapid action force is present. Number 8, we have got the complement cascade. So what is role of complement in the body's immunity? The complement does the job of opsonization. What do you mean by opsonization? It binds to the antigen. It binds to the antigen and attracts the immune cells to the site of infection. So basically it is what? It is the informer of the body. Informer. Complement binds to the antigen and attracts the monocyte to the site of infection. So they act as the informer of the body. And finally, the control room of the immune response are the cytokine system. The cytokine system is the control room of the immune response. It is the one which regulates the immune response. It is the one which regulates the immune response is what we have. So simple arrangement. The immune system is divided into the two types. Immune system is divided into the two types. We have got innate immunity, which is the more primitive form of immunity. So they are the watchmen and the policemen of the body. They are the weak one. The innate is the primitive one. But they are also very, very cleverly organized so that they can protect us against infection. So look from the top. So whenever the patient has got the antigen or pathogen wants to enter human body, when antigen or pathogen wants to enter the human body, the first defense we have is the anatomical barrier. We have got pattern recognizing receptor. We have got antimicrobial peptides, which are all non-cellular. The first cell is the NK cell. The special property is non-MHC restricted action. Then we have the monocyte macrophage system, which is the policeman of the body. Dendritic cell present the antigen. Granulocytes come in acute inflammation. Complement does opsonization and cytokine system regulates the immune response. So it is simple and clever immunity how it is arranged. But sometime when the threat level is high, robber के बदले terrorist, and threat level is high, the body has to call upon the army. Army is the adaptive system. Army is the adaptive system, is what we have, right? So yes, it is all in a cascade manner only. Cascade manner. It is always a cascadic manner. Once the immune cell is triggered, no, it will activate all the forms of immunity. So that is how immune system works. Positive reinforcement we call it. So adaptive system, army क्या लेकर आता है? Army brings the gun. The guns are the humoral or the B cell mediated immunity. The guns of the body, army brings guns. Guns of the body are the humoral or the B cell mediated immunity. Right? Is the B cell mediated immunity is going to be present. So what does the B cell have? What does the B cell have? The B cell is going to have expresses. The B cell expresses CD19 and CD20 on the cell surface. It expresses the CD19 and the CD20 on the cell surface. So like AK-47, the B cell have got CD19 cluster differentiation marker 19 and 20 on the cell surface they have got. So if I give you a gun, the B cell, and tell you to fire bullets, can you fire bullets? No. The gun has to be first loaded. Gun has to be loaded. So it needs the presence of the B cell, need the presence of either the BAF, also called as BLYS, is required. So what is that? B cell activation factor is required. B cell activation factor, also known as the B lymphocyte stimulator, is required. The B cell activation factor or the B cell stimulator is required so that they can activate the B cell. So the guns have to be loaded. The loading of the gun is done by the BAF, B cell activation factor, or the B lymphocyte stimulator is present. Once they combine together, then they join together. The B cells join together to form the plasma cell. So the plasma cells are the active B cell. They are the activated B cell or the loaded gun. Plasma cells are the activated B cell. That is the loaded gun is there, which in turn can secretes the antibody immunoglobulin. This in turn secretes the immunoglobulin, that is antibodies, which are like the bullets that we fire to neutralize the antigen. These are the bullets that we fire to neutralize the antigen. So that is how the story works. So when you call the army, army brings the gun. The guns are having CD19-20 marker, but they need to be loaded so that they can fire bullets which can kill the enemy. The B cells express CD19, CD20 and need the presence of activation factor to become the plasma cell, which in turn can secrete the immunoglobulin, also known as antibodies. also known as antibodies. But who is manning these guns? Who is giving the gun? Is the cell mediated, our commando. The cell mediated, also called the T cell mediated immunity. The cell mediated, T cell mediated immunity is present. And what do they have? They are the most potent level of the immunity. They are the most potent level of the immunity, and they express CD4 or the CD8 on the cell surface depending on whether they are helper or cytotoxic T cell. Whether they are helper or cytotoxic T cell, they are going to have the CD marker on the surface. The CD marker on the cell surface. So bring this whole immunity together. So immune system physiology is very, very important to know. Immune system physiology is very important to know. So immunity works in a very organized manner to avoid damage to self-antigen and also to avoid damage over activation. This is how immune system is arranged in the body. Clear everybody? Take some time. So what is the immune system doing? It is a well organized system. Again from the start, everybody read once with me. So immune system protects the body against antigen or pathogen. The innate immunity consists of 9 components. They are like the general security forces that we have. We have anatomical barrier, pattern recognizing receptor, antimicrobial peptide, non-cellular. We have got NK cell, we have got monocyte macrophage system, dendritic cell, granulocyte, complement and cytokine system. But when the threat level is high, we call upon the army, more modern, which consists of 2 humoral B cell mediated immunity or the T cell mediated immunity is present, right? So in majority of us, what is immune system? Immune system protects our body against infection. In all of us, in majority of us, the immune system protects the body against the antigen, infection. It defends us against. But today, we are not here to give him Paramvir Chakra. No. Today, we are there to criticize him. Because today we are here to study the pathology of the immune excess disorder. Today we are not here to tell good things about immunity. We are here to study the immune excess disorders. We are here to study the immune excess disorders that we are going to do. So the role of complement, Anadisha, role of complement is called opsonization. So what does opsonization do? Basically, opsonization means marks the target. It binds to the antigen and attracts immune cell to the site of infection. So complement in the blood will bind to antigen and attract monocyte to the site of inflammation. So this is like an informer. It is going to inform कि कहां पर छुपा है. It is informing the policeman कहां पर छुपा है robber. So that is the role of the complement system. So remember the components because we want to study pathology. First page is always physiology. Second page, extension, increase our depth of knowledge. Immune excess disorders also divided into 2. We have got innate excess disorder. We have got the innate excess disorders and small column, like we did for adaptive, small column, we have got adaptive excess disorder. Innate excess and the adaptive excess disorders are present. Adaptive excess disorders are present. Divide them into the two. So, immune excess disorders, like an extension of the physiology, can be divided into two: innate excess or the adaptive excess. So, tell me, the word that we use commonly, pathology, autoimmune disease, means which one? ऑटोइम्यून डिजीज मतलब कौन सा? इनेट एक्सेस, अडेप्टिव एक्सेस और एक्सेस ऑफ बोथ. किसको बोलोगे ऑटो इम्यून डिजीज? चलो टाइप योर आंसर्स. विच आउट ऑफ दीज टू इज कॉल्ड एज ऑटो इम्यून डिसऑर्डर्स विच आर वेरी कॉमन इन आवर वर्ल्ड टुडे? Correct answer is the adaptive excess disease, are also known as autoimmune disorder. It is the adaptive excess which is known as the immune excess disorder. Yes, Nival, very good. Happy to see you coming for rheumatology also. Yes. So autoimmune excess is the adaptive excess disease. Is called as autoimmune disorder. But in practice, most commonly the autoimmune diseases majority are organ specific. Most commonly the autoimmune disorders in practice are organ specific. They are organ specific. Example classical is the myasthenia gravis. The myasthenia gravis. We have got Graves disease. We have got vitiligo. And yesterday's example I am sharing with you. We have Goodpasture syndrome. We have got Goodpasture syndrome. We have got it here. So yesterday we studied in nephrology the topic of Goodpasture. है तो autoimmune but classical pulmonary renal syndrome. Goodpasture is classical pulmonary renal syndrome. Only two organs can be affected. So क्या हो जाता है? The organ specific autoimmune disease are treated by their subject specialist. मायस्थीनिया का ट्रीटमेंट न्यूरोलॉजिस्ट करते, ग्रेव्स का ट्रीटमेंट एंडोक्राइनोलॉजिस्ट, डर्मेटोलॉजिस्ट ट्रीट विटिलिगो एंड नेफ्रोलॉजिस्ट विल ट्रीट Goodpasture. But what about those people who have presented with systemic, that is multi-organ involvement? What about those patients who have presented with systemic autoimmune disease? Systemic means multi-organ involvement is present. Multi-organ involvement is present. They were miserable because they could not find any doctor who can understand their disease. They have got multi-organ involvement. And for them only we have started a new branch of medicine that is called as rheumatology. So understand, today's topic, rheumatology, is a study of systemic autoimmune disease. So today's class, rheumatology, is all about the study of systemic autoimmune disease. So you can understand all the diseases that we study today are going to be adaptive excess, autoimmune in pathology, and all of them will be multi-organ in involvement. All of them will be multi-organ in involvement. तो इसी को कहते हैं the rheumatology. They are called as. So coming to Shubhangi's question, why not both का मतलब नहीं है Shubhangi. Now it is like asking why is your name Shubhangi and somebody else's name is Akanksha or Anshika. Ana why मतलब क्या, नाम देने वाले का काम है. Ana your parents, your family named Shubhangi, like that. Scientist named autoimmune disease adaptive access को नाम दे दी. But don't worry, we'll complete this side also. So what are innate excess called? Innate excess are called as auto-inflammatory disorders. They are called as the auto-inflammatory disorders. Very good. So they are called as the auto-inflammatory disorders. They are called as. So compared to autoimmune disease, they are relatively rare and relatively milder than autoimmune disease. So these disorders are not often discussed because compared to autoimmune disease, innate excess disorders are very, very rare. And since innate immunity is a primitive form of immunity, the abnormality is also relatively milder. We can say. So auto-inflammatory disorders are a group of disease, but all the diseases in this group are inherited causes. And they present as recurrent fever. Most common presentation is the recurrent fever. They are called as. So all are inherited causes and they present as recurrent fever. And that is why they are also known as the familial. They are also known as the familial periodic fever syndromes. There are the familial periodic fever syndromes, also we call them, because of their presentation. Group में common points. So all auto-inflammatory disorders are inherited, and that is why they present with the recurrent fever. Hence they are also called as familial periodic fever syndromes. ये group है. This is a group of disorders, not one. It is a group of disorders. Periodic fever syndromes. But out of this group, the most famous disease we want to discuss in detail is the topic of FMF. FMF is the familial Mediterranean fever. FMF is the familial Mediterranean fever, which is considered the most famous, the prototype of this group. Means sample of this group. तो कल हमने पढ़ा diabetic nephropathy is considered as the sample for CKD because it is most common and most researched. Most common, most researched topic in this group is the topic of FMF. Familial Mediterranean fever is the most well-researched topic in this group. So what is this familial Mediterranean fever? It is an inherited defect. It is an inherited defect of the MEFV gene. Most commonly affecting epidemiology 10 to 20 years, male dominant disease. So this disease, familial Mediterranean fever, is an inherited defect of MEFV gene, which commonly affects adolescent boys. Adolescent boys is the most common age group getting the symptom of the disease. But what should happen? What is the pathology? Because of the defect, what happens? There is a overexpression. There is a overexpression of the inflammasome proteins in the body. There is an overexpression of inflammasome proteins in the body. But from the first page we know what are inflammasomes also called as pattern recognizing receptors. So we can understand what is the defect. Defect is in the sensor. In the FMF, the defect is in the sensor of the body. That means alarm system is faulty. Even though no antigen has entered into body, the alarm system is giving false trigger. Alarm system is giving false trigger, and that is why patient ends up coming with recurrent fever. So clinical feature, most common, they come with recurrent fever. They present with, but each episode of fever, each episode lasting only 3 to 5 days only, not prolonged, because it is a mild level of immunity. So once in a few days, the immune system will understand that it was a false alarm and it will reset. It will understand it was a false alarm and it will reset. So there is no real infection in this patient. But because of the false trigger by the inflammasome protein, there is a complaints of recurrent fever. Each episode lasting for 3 to 5 days. But we all know, along with fever due to any cause, what do we experience? We experience constitutional symptoms. We express constitutional symptom along with the fever, namely we experience body pain and anorexia along with weight loss. So these are common but non-specific features of inflammation. These are non-specific features of inflammation in the body. So along with fever due to any cause, whether it is a bacterial infection, whether it is viral infection, or it is autoimmune disease, what do we experience? We experience body pain. We experience loss of appetite. We experience weight loss. These are non-specific features of inflammation that can occur with the fever. But the specific site affected is the serous cavity involvement. The serous cavity involvement is the specific of the disease. Serous cavity involvement is specific for FMF. Hence the new name. They are also known as recurrent polyserositis syndrome. They are the recurrent polyserositis syndromes. They are called as the recurrent polyserositis syndrome. They are called as. So new name for FMF, they are called as the serous cavity inflammation is the specific feature of the disease. Specific feature of the disease. So that is why it is called as recurrent polyserositis syndrome. Recurrent polyserositis syndrome. We have got it here. So, which serous cavity is affected? We want to write it in order of commonness. Which serous cavity are affected? Serous cavity are affected in order of commonness. In the order of commonness, we want to write The most common serous cavity affected in the FMF is the pleuritis, followed by the peritonitis, followed by the synovitis, joint involvement, followed by the pericarditis, which is least common serous cavity affected in the disease. Less than 1%. Less than 1%. So patient is typically a young boy who is going to come with recurrent fever, body pain, anorexia and pleuritis. Then what does it look like? Tuberculosis. What can FMF do? It mimics TB. So if a young boy comes with fever, body pain, anorexia and pleuritis, the first thing in our country is going to be TB. Similarly, if a young boy comes with recurrent attacks of abdominal pain, tenderness and guarding, we think of appendicitis. Young boy में क्या होता है? Appendicitis. Young boy with recurrent fever, think of rheumatic fever. And viral infections can look like the pericarditis. Viral infection can look like the pericarditis. They can mimic. So FMF एक तो rare cause है, ऊपर से it looks like commonly occurring infection. FMF is itself rare and it mimics, it looks like more commonly occurring infection, and hence for diagnosis you require high suspicion. High suspicion followed by genetic testing. Followed by genetic testing is the gold standard of diagnosis. So you need to have high suspicion because they mimic much more commonly occurring infective conditions. Why the diagnosis is so important? छोड़ दो ना, fever ही तो आ रहा है. Tell them to take paracetamol every time they get fever. Should we manage that? Every time they get the paracetamol fever, should we okay? No. The drug of choice is colchicine. The drug of choice is colchicine. The drug of choice is colchicine, we can say. Why? Because colchicine not only relieves the symptom, it not only relieves the symptoms, not only relieves the symptom, but also induces remission. It not only relieves the symptom, but also induces remission, we can say. Also induces remission, we can say. Induces remission, we can say. Anna? So, एक बार, let's complete this topic. Relieves the symptom and induces remission. Induces remission. So, what is the dreaded complication if you don't treat? What is the dreaded complication in untreated cases? Suppose I don't diagnose, I don't give colchicine. What will happen? There will be accumulation of acute phase reactants. There will be accumulation of acute phase reactant, that is amyloid. Acute phase reactant, that is amyloid, can occur. तो ये हम लोग अलग से डिस्कस करेंगे. So we can also complete dialysis associated amyloidosis. सो इसको अलग रखेंगे. Amyloid means insoluble protein. Every time inflammation comes in the body, every time inflammation comes in the body, the acute phase reactants are produced in the body. These are insoluble protein. Insoluble protein means amyloid, which accumulate in the body. That is called as secondary amyloidosis. That is called as the secondary amyloidosis, which causes renal failure, which is the most common cause of death. Which is the most common cause of death before 40 years of age. So if you don't treat this problem, then inflammation itself is mild. But with every time inflammation, there is production of amyloid. Acute phase reactants are produced in the body, which put the burden on the kidney, leading to renal failure, which causes death before 40 years of age. Causes the death before 40 years of age. What is the differential diagnosis for the FMF? The differential diagnosis for the FMF is the very important topic FHF. That is the familial Hibernian fever. The familial Hibernian fever we want to discuss. The differential diagnosis for FMF is the familial Hibernian fever that we want to discuss. FHF, familial Hibernian fever. What is the problem here? It is an inherited defect. It is an inherited defect of the TNF alpha receptor. It is an inherited defect of a TNF alpha receptor, and that is why the new name for FHF, the new name for FHF is the TRAPS. It is the TRAPS. It is also called TRAPS, tumor necrosis factor alpha receptor associated periodic syndrome. Associated periodic syndrome. It is also called as. So the new name is the TRAPS. FHF is now called as TRAPS. FHF is now called as TRAPS. Epidemiology of FMF and FHF is the same, 10 to 20 male dominant. The most common feature also the same, पूरे ग्रुप में यही होता है, रिकरेंट फीवर है ना. फीवर हमेशा निखिल अक्यूट होता है रे बेटा, है ना, बिकॉज 3 days ही तो लास्टिंग है. अब 3 days में कैसे ग्रेजुअल करेगा? सडनली इन्फ्लेमेशन शुरू होता है. रिकरेंट फीवर, each episode for 7 to 10 days. Each episode for 7 to 10 days. So one point we must know, it is a fever, acute onset. Patient is fine, then starts falls ill. How we get a viral fever? Just like that. Suddenly patient falls ill. But here the duration of fever is longer. Duration of fever is longer and associated with a skin rash. Can be associated with a skin rash over the torso with ocular involvement is characteristic. Ocular involvement is specific feature of the disease. So along with fever, if a young boy complains of eye swelling, young boy complains of eye swelling, that is characteristic of the disease. The gold standard remains genetic testing. Gold standard is to go for genetic testing. Here the drug of choice is steroids because clinical trials they have better response than colchicine. In clinical trial, steroids show better response than colchicine in a patient of TRAPS. Here also, the dreaded problem is secondary amyloidosis. The dreaded problem is the secondary amyloidosis. Dreaded problem is the secondary amyloidosis. So, in both the disease, you can say that early treatment in both the disease both results in good prognosis because the disease itself is not, but it is the recurrent inflammation which causes the deadly complication of amyloidosis. So once you treat the patient has got a near normal life. He's got a near normal life. Right? It has got a near normal life. We need to go for. Early treatment in both results in a good prognosis, we can say. Results in the good prognosis, we can say. ठीक है? वन बाय वन करके आएंगे. ओके टिल हियर. सो वन क्वेश्चन, विराट का क्वेश्चन क्या है? साइनोवाइटिस. है ना? साइनोवाइटिस इज आर्थराइटिस ओनली बेटा, है ना? जॉइंट इन्वॉल्वमेंट, दैट इज आर्थराइटिस. जॉइंट इन्वॉल्वमेंट, दैट इज आर्थराइटिस. राइट. सेकेंड क्या है? अंशिका. है ना? वेट अभी वेट, है ना? अभी अप्रोच पढ़ाऊंगा मैं, है ना? डोंट वरी. सिम्टोमेटोलॉजी आया नहीं है ना, पढ़ लेते थोड़ा सा. हाँ. सो आगे इसको सॉल्व करेंगे, है ना? सो निखिल के लिए क्या है? अक्यूट प्रेजेंटेशन. इट इज अ अक्यूट प्रेजेंटेशन ओनली. ओके. सो वेरी वेरी इंपॉर्टेंट ग्रुप ऑफ द सिंड्रोम. Very very important group for MCQ. Will the MCQ? Yes. At Madhavi, yes. Anna. So till treatment, yes. Unless treated. So unless you treat, that is why the problem, no? Unless you treat, the problem will persist for life. It's a genetic disease. So that is why you have to control the inflammation. That is why we have to control the inflammation. That's what we have to do. So take it on top. क्या हमने पढ़ा? The immune excess में we completed the topic of innate excess disorder. We completed the topic of the innate excess disorder. The innate excess disorder we want to treat. So they are rare and mild as compared to autoimmune disease, but all are inherited, presenting as recurrent fever. Hence they are also called familial periodic fever. In the familial periodic fever, we have to compare FMF versus FHF. So in the familial periodic fever, if I have to compare FMF and the FHF, इसको ध्यान से देखना. FHF and the FMF, we have to compare in a auto-inflammatory disease. This is just a revision. 10 to 20 years, male-dominated disease. What is the defect? What is the new name? We want to know what is the defect, what is the new name of the disease is important. The duration of fever is important. The duration of fever episode is important. to differentiate in MCQ and practice. We must know here what is the drug of choice, what is the specific organ involvement and the drug of choice. What is the specific organ involvement and what is the drug of choice? We want to know. Specific organ involvement, drug of choice we want to know, because the dreaded complication is same in both. The dreaded complication is same in the both, and the cause of death in both is renal failure. The cause of death in both is renal failure. And at Div, yes, you have to continue lifelong treatment because there is no permanent cure. When the cause ही नहीं पता तो cure भी नहीं कर सकते. So you continue the long-term treatment. We have to continue. Long-term treatment we have to continue. So quickly recap for me. हमने जो पढ़ा ऑटो इन्फ्लेमेटरी डिजीज, क्विकली रिकैप फॉर मी. सो द न्यू पॉइंट FMF, द डिफेक्ट इज इन द PRR ओवर एक्सप्रेशन. The pattern recognizing receptors are overexpressed. The new name is the recurrent polyserositis syndrome. Please remember, any name with geographical reference. So any name with reference to geography and name of the scientist is no longer preferred. Name of the scientist is no longer preferred. Scientist name is no longer preferred. So ये दोनों हम prefer नहीं करते. New name is based on pathology. New names of the disease are based on pathology, descriptive term. So any name which contains reference to geography, reference to name of scientist is no longer preferred. So Mediterranean बोलना गलत है, because सिर्फ Mediterranean में नहीं होता. This disease can occur anywhere in the world. So these names are no longer recommended. The duration of fever is 3 to 5 days only. The specific organ involved is the serous cavity. The drug of choice is colchicine. We have got. But differential is FMF. FHF is the differential, where defect is in the TNF alpha receptor. That is why new name is TRAPS. The duration of fever is longer, 7 to 10 days. Specific organ involvement is ocular and the drug of choice is steroids. Drug of choice is steroids. You have to give lifelong treatment to prevent this dreaded complication. To prevent this dreaded complication, we must know. So before we complete auto-inflammatory and switch to rheumatology, एक extra point जो कल का balance था is the topic of amyloidosis. So quickly एक लिख लेते हैं please. Connection between nephrorheumat कल का amyloid. Amyloid means insoluble protein. Amyloid means insoluble protein. It is there. Amyloid means insoluble protein is present. Insoluble protein. Accumulation of the insoluble protein. Accumulation of the amyloid, insoluble protein, is the amyloidosis. Insoluble protein is the amyloidosis. So based on the type of, based on the insoluble protein amyloid in the disease, the names are given. Disease, the names are given. the names are given, we can say. So amyloid means insoluble protein. So accumulation is called amyloidosis. Based on the amyloid in the disease, names are given. For example, in primary amyloidosis, it is also known as AL type of amyloidosis. What is AL type? A for amyloid. So amyloid light chain, which is associated with multiple myeloma. That's why it is called primary amyloidosis. हम इसको बोलते हैं. Secondary amyloidosis that we just studied. Secondary amyloidosis is the AA type of amyloidosis. A for amyloid, second A for acute phase reactant. Acute phase reactant is there. Acute phase reactant is accumulating in the body. So this can occur in chronic infection. Example, tuberculosis. Example, MDR, XDR, TB. It can occur in immune excess disorders. That we just saw. And we have got dialysis associated amyloidosis. Which is known as A beta 2 microglobulin type. So complete point here. So A beta 2 microglobulin type, because here there is accumulation of beta 2 microglobulin in the body. Where does it accumulate? It accumulates in the musculoskeletal system. It accumulates. That is why most commonly they present with the entrapment neuropathy. Carpal tunnel syndrome, wrist drop, etc. But the dreaded complication of the beta 2 deposit, the dreaded feature is they can develop paraplegia. Due to paravertebral ligament involvement. Can lead to paraplegia. So this is associated with both 3 or more years of dialysis. It can occur 3 or more years of dialysis because neither the HD hemodialysis nor the PD can excrete the beta 2 microglobulin. And that is why the only treatment is a renal transplant. Can be done here. So very simple points. We can see amyloidosis, which are they? So amyloidosis, primary amyloidosis is the one which is amyloid light chain associated with multiple myeloma. Secondary amyloidosis is the amyloid acute phase reactant, which we just saw with immune excess condition. And yesterday we studied dialysis. So neither form of dialysis can excrete beta 2 microglobulin. So they accumulate in musculoskeletal system, which can cause entrapment neuropathy, or patient can come with dreaded complication. The only treatment is renal transplant. So I don't know where you are reading it. Okay. So aluminium toxicity is a thing of the past. It is a thing of the past, obsolete. Now the present modern filters don't contain aluminium. The modern filters have no aluminium. That is why this toxicity is outdated. है ना? So ये सब मत पढ़ना, ये सब क्वेश्चन भी सॉल्व मत करना. That's why don't waste time on old questions. Okay, look only at new questions. Look only in the new questions. हो गया क्लियर? हमने पढ़ लिया. Amyloidosis also overview कर लिया. Amyloidosis also overview we have studied. Overview of amyloidosis we have studied. Right, everybody? So bring the session together. Bring the session together. We want to know. So amyloidosis का मतलब होता है insoluble protein. Obviously, because they are insoluble, they put the pressure on the kidney. The burden is on the kidney. Burden is on the kidney. That's why renal failure is a common problem. That is why renal failure is common problem. Because these protein needs to be excreted by the kidney. Right? So this is for our अमूल्य, है ना? So जो आपका रह गया था कॉपी कर लीजिए. So we can move forward. We can move forward. इसको आगे चलाते हैं. Right? So निखिल, ये सब जो हाइपरटेंशन है we will cover in cardiology. Don't worry. इतना कुछ important नहीं है. कार्डियोलॉजी में पढ़ लेंगे. रीनोवैस्कुलर हाइपरटेंशन कर लेंगे. ओके, फेयर इनफ. ओके एवरीबडी विथ मी. सो हमने कहा आ गए अभी? इनेट एक्सेस डिसऑर्डर चैप्टर क्लोज. इनेट एक्सेस डिसऑर्डर का चैप्टर क्लोज करें क्या? है ना? इनेट एक्सेस डिसऑर्डर, क्लोज दिस चैप्टर कंप्लीटली. So we completed the topic FMF and FHF. These are both familial periodic fever syndrome. And we also studied overview of dialysis with yesterday's topic, dialysis associated amyloidosis. Dialysis associated amyloidosis. इसको कर लेते हैं. So now we are ready to start with our topic, that is rheumatology, class topic. So announce किया rheumatology और 1.5 hours तो चला गया in reviewing basic words. 1.5 hours importantly invested in basic words, in the basic words. Now let us come to rheumatology. Chalo, write down. So what is this overview? Let us write down of rheumatology. What is the overview of rheumatology? We are going to think of. Overview of rheumatology. We are going to think of. So rheumatology में, है ना, what we have to do? In rheumatology, it is a study of systemic autoimmune disease. It is the study of systemic autoimmune disease. It is the study of systemic autoimmune disorders. It is the study of the systemic autoimmune disorders is rheumatology. The study of systemic autoimmune disorders is rheumatology. Rheumatology typically affects young age females. Typically affects young age females of the childbearing age group हम इसको बोलते हैं. So we are taking a overview of rheumatology. Rheumatology, what we have to study is commonly affecting young females. The etiology in majority is idiopathic, unknown, and that is why the target of treatment is remission, not cure. The target of treatment is remission. No cure is possible. The target is only to induce remission. Cure नहीं कर सकते. So we don't know how to manage the disease. But what is the clinical feature? So in short, you want to learn approach to the disease. When the patient presents with recurrent unexplained fever, that is pyrexia of unknown origin. This is our presentation, which is commonly associated with the constitutional symptom may be present. Non-specific symptom may be present. So along with the fever, patient is saying anorexia, myalgia and weight loss can be present. So हम क्या बोलते हैं? Presentation. When patient comes with recurrent unexplained fever along with constitutional symptom, PUO, along with constitutional symptom, what we are going to do? We have got three differentials. Remember this. There are three differentials that are there. For Anshika. So when to suspect? So when do you say PUO? Typically we say PUO after excluding common infection. After excluding common acute and chronic infection. So which are the acute, chronic infection and acute infection in the practice? Acute and the chronic infection in the practice. So when patient in India comes with fever, सबसे पहले क्या क्या चेक करते हैं? CBC, PS for MP, malarial parasite, urine routine, we do Vidal test and chest X-ray. बराबर है? So what is practical approach in our country? When the patient comes with fever, you are going to consider giving the patient CBC, PS for MP, urine, Vidal and chest X-ray. If they are negative, then we do HIV, Hep B, Hep C and TB testing. And even if the TB tests are negative, then we call it as PUO. Just 1 minute, please. Right. So we call this as PUO. So after excluding these points, so what we can say, after excluding these common acute and chronic infection, पहले तो यही सोचने का, उसको treat करने का. When patient remains symptomatic in spite of routine testing, then we call them as PUO. Then we call this patient as having PUO. We call this as. In the patient of PUO in our country, most common cause remains occult infection. So it can be occult infection. Most common in our country is still TB only. It can be subacute bacterial infective endocarditis could be present. That is why we then do the rare test we do. So when patient comes with the unexplained fever with constitutional symptom, first thing we look for occult infection only. After excluding occult infection, you think of immune excess disorder. Among the immune excess, more common is the autoimmune disease. In the autoimmune disease, you want to do antibody screening, which we will study. We do antibody screening. If the antibody screening is negative, then I am going to look for the genetic test, auto-inflammatory disorders. I'll have to consider, abhi genetic laga to laga. So it is rare, no, कि इतना दूर तक आएगा patient. So genetic testing becomes indicated in this patient. And when this is also negative, we think of neoplasm, which is rare. So here you go for a whole body PET CT, etc. You will have to do whole body PET CT, bone marrow, endless ho jata hai. So evaluation is always a matter of most common to least common. You always investigate in order of most common to least common. So when our patient is going to come with fever, in our country still infection is king. Infection is not there, then we think of autoimmune disease. Autoimmune is also not there, then rare disease, autoinflammatory and neoplasm we may want to think of. But today's topic, if autoimmune disease has the clinical antibody positive, has got multi-organ involvement, then what you do? You suspect rheumatology disorder. That is when you suspect the rheumatology disorders we want to think of. So this is the topic, symptomatology of rheumatic disease. Symptomatology of rheumatic disease is the multi-system involvement. Autoimmune disease we will think of, rheumatology disorder we will think of, right? So use this approach table. So when patient comes, typically young female, because age group is most commonly young female, comes to you with unexplained fever after excluding infection. Think of immune excess disease. In immune excess, do antibody screening. Antibody positive with multi-organ involvement, refer to rheumatology. Negative, think of genetic testing or neoplasm, whole body PET CT, etc. you want to do. So this is the approach, clinical approach to suspect rheumatology disease. So we know rheumatology diseases are common in young female. Majority are occurring in young female. They present with recurrent fever with constitutional symptom. After excluding infection, think of autoimmune. Multisystem refer to rheumatology. Multisystem refer to rheumatology. So take it forward. What is the classification of? What is the classification of the rheumatology disorders? What is the classification of rheumatology disorders? We want to know. So we know when to suspect rheumatology, we know. Now we want to classify rheumatology disorders so that we know कि क्या topics होते हैं rheumatology में. Let us try to remember. So rheumatology diseases are broadly classified into three main groups. We divide them into three main groups. When the patient comes with rheumatology disease, you classify them into three main groups. Write down the groups. The three main groups are based on, they are classified into three main groups. These groups are based on, they are based on the characteristic feature. They are based on the characteristic feature if present. Based on the characteristic feature if present, and or the screening antibody present, and or the screening antibody present. Any one we need. Both are there, very good. At least one we need for classifying the patient into the group. So rheumatology disease, we are broadly going to classify them into three main groups based on characteristic feature if present. It's not always present. And or the screening antibody positive. So which are the three main groups? The most famous you know is the lupus group of disease. Most common in rheumatology are the lupus group of disease. We have got arthritis group of disease. The arthritis group of disease are also sometimes known as connective tissue disorders. They are also counted sometime under the group connective tissue disorders. And we want to study about vasculitis group of disease. CTD is connective tissue disorder. Connective tissue. Arthritis syndromes are also sometimes put under connective tissue disorder. But they are all part of rheumatology disease. They are part of rheumatology disease that we want to study. So when will I say patient has got lupus group of disease? When a young female presents to me with the lupus rash. Lupus means wolf. So wolf bite like skin rash. Wolf bite like skin rash is present. Wolf bite like skin rash is present, or the patient is ANA positive. Patient is having ANA positive. I will first suspect that it is lupus group of disease. I will first suspect lupus group of disease. But if the patient comes to me with joint deformity, patient presents with a joint deformity to me, and the patient is RA factor positive. RA factor is rheumatoid factor positive. Common question, what is rheumatoid factor? It is an IgM type of antibody against the Fc portion of IgG. against the Fc portion of IgG is Ra factor. So if a young female comes with joint deformity or has got Ra factor positive, you will think of arthritis group of disease. Or if a patient presents with purpuric skin rash, patient comes with a purpuric skin rash and along with good posture we studied yesterday, ANCA positive. Along with good posture we have written ANCA positive. Then we suspect vasculitis group of disease. We can call them vasculitis group of disease. So first step, what I will do, if a patient comes to me with unexplained fever and infection is not there, after excluding infection, I will think of autoimmune disease. In the autoimmune disease, if they have multi-organ involvement, I will think of rheumatology. So I will see whether they have got lupus rash, whether they have got joint deformity, whether they have purpuric rash over skin. If it is present, then the diagnosis is easy because these are characteristic feature of the group, but not always present. If they are not there, I will have to do screening antibody of each group. I will have to perform screening antibody of each group. Depending on which is positive, I will put them into the group. Depending on which screening antibody positive, I will put them in that group. Further evaluation in the lupus group. Further evaluation is based on the specific feature. It is further based on the specific feature. The specific feature and the specific feature and the specific antibody present. Based on the specific feature and the specific antibody present, I can reach the final diagnosis in this group. So within the lupus group, all are ANA positive, all can have skin rash, all of them can have the skin rash, can be present in all of them. But based on the specific feature, if present, based on the specific antibody present, I am going to give them the final diagnosis. I am going to reach the final diagnosis. The final diagnosis, most common lupus disease is the SLE. Most common lupus disease is SLE. I will reach the diagnosis. Differential for SLE is the scleroderma. Differential for SLE is the scleroderma, which is now called as SSC, that is systemic sclerosis. It is called as the SSC, that is systemic sclerosis. It is called as. And we have got Sicca syndrome. And we have got the Sicca syndrome, which was previously also known as Sjogren's syndrome. As I told you, name of the scientist is no longer preferred. Name of the scientist is no longer preferred. Better to describe the feature Sicca as the presenting name. Sicca syndrome. We can divide them into. In the arthritis group, based on the pattern of joint involvement, based on the pattern of joint involvement, I will reach the diagnosis as most common arthritis, RA. Rheumatoid arthritis can be there. Differential for RA are the SPAs. SPAs are arthropathies. Pathies, okay, this is plural. The spondyloarthropathies, or it can be a case of crystal-induced arthropathies. Can be a case of crystal-induced arthropathies. We can say case of crystal-induced arthropathies. The ANCA positive vasculitis are based on the size of the vessel involved. The size of the vessel involved. We divide the vasculitis syndrome into three again. We have got large vessel vasculitis, medium vessel vasculitis, and the small vessel vasculitis. Medium and the small vessel vasculitis, it is called as. The small vessel vasculitis, it is called as. Divide them into three groups. So rheumatology है ना, very simple topic, very evidence based topic. Okay, so please remember, in the Western country, rheumatology is increasing. अपने country में still infection is there, but once you exclude infection, we must consider differential of immune excess disease. Among the immune excess, majority will be autoimmune, majority will be organ specific. Refer them to specialist. But if they are multi-organ, these are the patient who require rheumatology opinion. So what you will do? You will look for characteristic feature and ask for screening antibody. Depending on them, you will give them a name and then refer to rheumatologist. कि भाई suspected lupus problem, suspected case of arthritis or vasculitis syndrome. Refer the patient to the rheumatologist is what we do. Refer the patient to rheumatologist is what we will do. But further here, we have got some new topics here. We have also got myositis syndromes. So in rheumatology, the new entries we have got are the myositis syndromes. The myositis syndromes also have got the screening antibody as ANA. So add one more black line. Below the red line, we will add a black line for myositis syndrome. Black line for myositis syndrome. So in rheumatology patient, ANA positive, most commonly lupus, but it can also be positive in myositis syndrome. Which are the myositis syndrome we want to study? The most common classical is the polymyositis. The most common, the classical is the polymyositis. We want to study the topic of dermatomyositis. And we have got the rare, that is inclusion body myositis. We have got the inclusion body myositis we want to discuss. Inclusion body myositis we want to discuss. So myositis also, which were previously part of neurology, are now covered in rheumatology because the common pathology is inflammatory. They are inflammatory with ANA positive. They can be ANA positive. There will be few patients in your clinic who are positive for both ANA also and RA factor also. There are few patients who you will find who are positive for both ANA also, RA factor also. What to call them then? They are called as overlap syndromes. Because they have antibody of both group, they are called as overlap syndromes. They are called as the overlap syndromes. These overlap syndrome based on the specific antibody. Based on the specific antibody, if present, not always present, if present, are classified into two. They can be MCTD, mixed connective tissue disorder, or lupus. Mixed connective tissue disorder or lupus, they can be. Mixed connective tissue disorder is a disease. Overlap is a group of disease. And we want to finish with the topic of fibromyalgia. We want to finish with the topic of fibromyalgia, which is part of the central sensitivity syndrome. Which is part of the central sensitivity syndrome. हम इसको बोलते हैं. So in rheumatology mainly consists of three main groups and three chintu points. So three main groups in rheumatology are lupus group, arthritis group, vasculitis group. Chota topics are myositis syndrome, overlap syndrome, and fibromyalgia. These are chota topics: myositis, overlap syndrome, and fibromyalgia, which we want to discuss under the section rheumatology, right? So you will see that rheumatology is very, very interesting, because in MBBS rheumatology is very, very understudied. For most MBBS candidate, rheumatology में क्या है? They will say SLE and RA and it stops. But today we know what is rheumatology. It is a study of systemic autoimmune disease. And we know that rheumatology has got many disorders that we want to discuss in this group. Many disorders that we want to discuss in this group. So, before we discuss, what is important to know? Screening test. So, yesterday also we saw what is the screening test in suspected. What is the best screening test in suspected autoimmune disease? In the suspected autoimmune disease, what is the screening test? In a patient with suspected autoimmune disease, the suspected screening test is ANA testing. Single best answer is the ANA testing. Single best answer is the ANA testing. Anti-nuclear antibody. Anti-nuclear antibody we are going to study. Anti-nuclear antibody testing is the most common antibody. ANA is the most common antibody. Most common antibody present in autoimmune disease. Present in the autoimmune disease. Present in the autoimmune disease. Present in the autoimmune disease is there. Most common antibody present in autoimmune disease with more than 98% sensitivity. With 98% sensitivity, making it the screening antibody. Making it the screening antibody. Making it the screening antibody we are going to do. So single best screening antibody. Single best screening antibody. So I'll show you कि rheumatology suspect कब किया मैंने? Antibody autoimmune किया. The single best antibody testing is the ANA. Single best antibody testing is ANA. ये single best. If the feature is not there, then single best to do is the ANA screening. single best test to do is the ANA screening we want to do. चलिए एक बार और दिखा देते हैं और फिर आगे बढ़ते हैं. राइट अंशिका आगे पढ़ेंगे है ना. वील स्टडी अबाउट द फाइब्रोमाइल्जिया है ना. देयर इज नो स्क्रीनिंग एंटीबॉडी लाइक दैट. वन बाय वन वील अनरेवल द मिस्ट्रीज. नो अभी तो नया टॉपिक है ना. वेट फॉर वन थिंग टू ऐड, देन एज वी गो अलोंग वील अंडरस्टैंड द टॉपिक बेटर. अंडरस्टैंड द टॉपिक बेटर. ठीक है आगे चलें. प्रकृति प्रीवियस स्लाइड डन. आगे. So we want to start with the screening antibody is the ANA testing. But the ANA testing is available by two methods. ANA testing can be done in practice using two methods. So याद करते हैं what was screening antibody in nephrology. In renal disease we had two, the creatinine and cystatin C. याद करिए उसी स्टेज पे आए हैं. So yesterday in nephrology also we studied the first physiology. Today we have studied the physiology of immune system. We have written inflammatory disease. Come to methods. So ANA testing can be done by two methods. The ELISA is the preferred method. ELISA is the preferred method, but the ideal method is the immunofluorescence method. Ideal method is to go for immunofluorescence method, like we saw yesterday. Screening test in renal disease, preferred is to go for creatinine, but ideal is to do the cystatin C. Preferred is creatinine, ideal is cystatin C, because cystatin C was more specific also. But problem is it is not easily available and it is also expensive. So for routine screening, preferred test was creatinine. Same way, in suspected autoimmune disease, the preferred test is ANA by ELISA. But ideal method is immunofluorescence method. And there is no one, there are two reasons. There are two reasons why immunofluorescence is the ideal method. There are two reasons why immunofluorescence is the ideal method. Reason number A. Reason number A, it is ideal because it is a quantitative method. It is a quantitative method. Quantitative. So the result of the test, the result gives me antibody titers. It does not just tell me that whether ANA is present or absent. It tells me antibody titers. Why it is important? Because ANA titers more than 1:160 are considered significant for the diagnosis. Significant for the diagnosis of autoimmune disease. So ANA only positive not enough. It has to be present in more than 1:60 titer to be considered significant for autoimmune disease, because lower titers of ANA, the lower titers of ANA may be found in almost 20% of the normal population. Almost 20% of normal population, especially in females. Especially females. That means it will be false positive. It can be false positive. Lower titers do not mean autoimmune disease. They do not indicate autoimmune disease. They are only autoimmunity. So presence of ANA alone, presence of the ANA in lower titers is known as autoimmunity, not autoimmune disease. It is known as autoimmunity, not autoimmune disease. Okay, so there is a difference between the two. Autoimmunity, autoimmune disease. There is a difference between the two. There is a difference between the two. So quantitative test. It is first reason number A. Reason number A, why immunofluorescence is ideal method. Because the result gives me antibody titer only when the titers are more than 1:160. They are significant for the diagnosis of autoimmune disease. Significant for diagnosis of autoimmune disease. Right? So lower titers may be found in the physiology also. Lower titers are considered false positive because they are not part of autoimmune disease. They are only called autoimmunity, not autoimmune disease. So let me give you analogy. Listen carefully. Analogy is very simple. Autoimmunity एंड ऑटो इम्यून डिजीज में क्या फर्क होता है? ऑटो इम्यूनिटी इज प्रेजेंस ऑफ ऑटो एंटीबॉडी. ऑटो इम्यून डिजीज इज व्हेन द प्रॉब्लम कैन कॉज ऑर्गन इंजुरी. ये किसके जैसा है? इट इज लाइक हैविंग ब्लड प्रेशर एंड हाइपरटेंशन. इट इज लाइक हैविंग ब्लड प्रेशर. ब्लड प्रेशर होता है क्या हम सब में? होता है. But when BP more than 130/80, it can cause target organ damage. That is why we call it disease. So in a female, especially after pregnancy, finding low titer of ANA is very common. So in female, especially after pregnancy, finding ANA is very common. But most of them have ANA in low level. It is like having blood pressure, nothing to worry, autoimmunity. But only when the levels of these antibodies become high can they potentially cause organ damage. Then they are considered significant for autoimmune disease. But what is problem with ELISA? ELISA is a qualitative test only. It is a qualitative test. So it will only tell me positive or negative. ANA, whether it is positive or negative, it will tell you. And hence it may be false positive. Just like who? Like our creatinine. Hence may be false positive also. Because it is not telling me the titer. It is not telling me the titer. So like creatinine may be false positive in athlete, like that ELISA may be false positive, especially in female. That is not going to be enough. Why do we do it at all then? We do it because it is easy availability. There is easy availability is present. Easy availability is present. Easy availability is present. It is cheaper and it has got equal sensitivity. It has got equal sensitivity to exclude the diagnosis. Equal sensitivity to exclude the diagnosis. That is important to know. So if the ANA is negative by ELISA, if the ANA is negative by ELISA, then what I can say? It is no autoimmunity present. I can say no autoimmunity present. like creatinine. If creatinine is normal, renal function is definitely normal. But in athlete, there may be false positive. Then you counter check the cystatin C. Same way, in the screening, I will first do ANA. ANA is negative by ELISA, forget about it. But ANA is positive by ELISA. To know whether it is significant or false positive, I will have to do immunofluorescence method. In the immunofluorescence method, I will confirm if the titers are significant. But what's the problem? The ANA is sensitive. Yes, but we have written in the previous page itself. Suppose the patient is come. Example, patient is ANA positive with multi-organ involvement. Patient has got multi-organ involvement. So you can say that she is having rheumatology disorder. So that is clinical, no? Rheumatology disease is suspected. But within rheumatology disease itself, ANA can be positive in 3 groups of disease. It can be still positive in 3 groups of disease. Hence, it is not specific for diagnosis. So, ANA is sensitive, yes. Sensitive, yes. But it cannot tell you the diagnosis. So, it is a screening test because ANA can be positive in lupus disease also, myositis syndrome also, overlap syndrome also. It can be positive in. So who will help me? Who will help me is the immunofluorescence pattern. So what I will do? The second advantage. The second advantage of immunofluorescence method, 2 reasons may say. A, quantitative confirms significance. B, the immunofluorescence pattern. B, immunofluorescence pattern can tell you the corresponding antibody present. The immunofluorescence pattern can tell you the corresponding antibody present. This corresponding antibody can tell you the probable diagnosis. So ANA is not specific of the disease, but still I want to know what is the probable diagnosis mujhe chahiye. For that, the help will come from the immunofluorescence pattern of ANA. It will come from immunofluorescence pattern of ANA. If the pattern of ANA on immunofluorescence is homogeneous pattern. Homogeneous pattern is also called as diffuse pattern. Also called as diffuse pattern. It corresponds to the presence of anti-dsDNA, double-stranded DNA, or the presence of antihistone antibody. The dsDNA is specific for idiopathic SLE. The antihistone is common in drug-induced SLE. But whichever it is the most common pattern in SLE. It is the most common pattern in a patient of SLE. I can say that whichever the pattern, whichever the antibody, whether it is dsDNA or whether it is antihistone, will only change the cause, not the disease. Most common pattern in SLE. If you get rim pattern on the immunofluorescence method, the rim pattern corresponds to the presence of anti-Smith. Corresponds to the presence of anti-Smith in the plasma, which is the most specific antibody for SLE, making it the most specific pattern in SLE. Most specific pattern in SLE is the rim pattern. Most specific is the rim pattern. So understand, right? So if a young female comes to you with unexplained fever, you did ANA. ANA by ELISA was positive. So you repeated ANA by immunofluorescence. In that you confirmed that titers were significant. And if the pattern was homogeneous or rim pattern, you will say most likely diagnosis is SLE. Investigate and confirm. But if the ANA is positive in centromere pattern, ANA positive shows centromere pattern. Centromere pattern corresponds to presence of anti-centromere antibody. Corresponds to the presence of anti-centromere antibody, which is specific for CREST syndrome. Which is specific for CREST syndrome, which is also known as limited form of systemic sclerosis. Limited form of systemic sclerosis we can identify. Second disease, lupus group में index we have put second disease, systemic sclerosis, scleroderma. If the ANA shows nucleolar pattern, ANA shows nucleolar pattern of immunofluorescence, then we can say it corresponds to the presence of anti-topoisomerase 1. The anti-topoisomerase 1, which is commercially called SCL70. Topoisomerase 1 is also called anti-SCL70, which is specific for the diffuse systemic sclerosis. Diffuse systemic sclerosis. It is diffuse systemic sclerosis. But if you get speckled pattern of ANA on immunofluorescence, speckled pattern can be seen with anti-Rho, anti-La, which are now called as SSA and SSB, which are specific for Sicca syndrome. Which are specific for Sicca syndrome. They are the specific antibody for the Sicca syndrome. The speckled pattern can also be seen with anti-Jo. Anti-Jo antibody is most specific antibody seen in polymyositis. Seen in the polymyositis, and it can also be associated with anti-U1 RNP. Anti-U1 RNP is specific for MCTD, mixed connective tissue disorder. That is part of overlap syndrome. That is part of the overlap syndrome. Yes. So this is the point that we want to learn. So yes, of course, we are going to see the whole slide also together. We are going to see the images also together. So draw it with me first. Immunofluorescence pattern. You will see. Immunofluorescence pattern can tell you whether the patient is suffering from lupus group of disease. This is just for your understanding. Lupus group of disease, myositis syndrome, or the overlap syndrome. Myositis or the overlap syndrome. We have written no, ANA is positive in all of them. ANA positive in rheumatology. ANA positive in a rheumatology disease can be either due to lupus or due to myositis or due to overlap syndrome. So we can try to make a probable diagnosis based on the immunofluorescence pattern. Make a probable diagnosis based on the immunofluorescence pattern. That will tell you probable diagnosis. Probable diagnosis. So significant titer में होना चाहिए. Then the diagnosis we take it forward. क्लिनिकली देखेंगे मल्टी ऑर्गन भी था तो यू कॉल इट रूमेटोलॉजी एंड इन दैट स्टैटिस्टिकली कॉमन इज ल्यूपस ग्रुप फॉलोड बाय मायोसाइटिस फॉलोड बाय ओवरलैप सिंड्रोम. सो कैसा है ना, स्टेप वाइज अप्रोच होना जरूरी है. स्टेप वाइज अप्रोच इज एसेंशियल. The step-wise approach is essential in this patient. So here, what I'm going to do, let us just put our images and see. Right. So let us recap the topic we have done till now. So what is this rheumatology? It is the study of systemic autoimmune disease. It is the study of systemic autoimmune disorders that we have started with today. We have studied with the systemic autoimmune disorders. Rheumatology we have started today. So what we know in rheumatology, we have become now a good MBBS in rheumatology. We have become a good MBBS in rheumatology in this session. How we have become good MBBS in rheumatology? Because we can do early suspicion. For early suspicion, you know what are the content of rheumatology. How to suspect rheumatology disease. We have written, right? Approach table. Number 2, we have to do early screening. And best single answer for early screening was ANA testing, which can be done using both ELISA, immunofluorescence method, and then you perform early referral to rheumatologist. Early referral to the rheumatologist we want to do. So in this session, we have completed early suspicion, early screening, and early referral. In the further sessions, we want to start our fellowship in rheumatology. For the fellowship in rheumatology, we have to do 3 sessions. The fellowship in rheumatology will consist of 3 sessions. So one session we will be completing, today's session, we will be completing lupus, myositis and overlap syndrome. Lupus, myositis, overlap syndrome. Tomorrow we will start with arthritis syndrome and we will finish with vasculitis syndrome with fibromyalgia. And the fibromyalgia we want to study tomorrow. So this is our plan. Okay. So rheumatology का plan देख लेते हैं. So rheumatology plan is that we are going to divide our sessions like this. The first session we have completed now. We have become a good MBBS in rheumatology. Then we will do lupus myositis today, arthritis vasculitis tomorrow. So right. So tell me, what did we study now? We started with auto-inflammatory disease also. The auto-inflammatory disorders were relatively rare. But which are the two? The differences was the FMF versus TRAPS. FMF versus TRAPS was the differential. In the TRAPS, what did we see? There is defect in the TNF alpha receptor defect. TNF alpha receptor defect is there. Each episode of fever is lasting for 7 to 10 days. 7 to 10 days. Specific feature is the skin involvement and the ocular involvement. So skin involvement and the ocular involvement was specific to the symptom, specific to the disease, that is TRAPS. Drug of choice was steroids. Prognosis was good if you could do early treatment. Take it forward. In rheumatology, in a patient with suspected autoimmune disease, the best screening test is ANA. But ANA by ELISA is the ideal because it gives you immunofluorescence pattern and titers. So look at the pattern. When the titers are more than 1:160, then you will call it as significant, and then only you will look at the pattern. Based on the pattern, you can give probable diagnosis. Based on the pattern, you can give a probable diagnosis is what we learned. I hope this is clear to you. Since this is a little topic which we don't do routinely, I'm going slow. So don't give me dirty looks, please. Anna, we'll just complete on time. Don't worry. So probable diagnosis we want to see. So what are the patterns you have seen? Homogeneous pattern, uniform staining, speckled pattern, nucleolar pattern, centromere pattern we have seen. Number one, if there is a homogeneous pattern, you can see the staining, how it is uniform staining. No problem. There is a uniform staining of the cell. When you stained for ANA, immunofluorescence method, there is a uniform staining, homogeneous pattern. We also is associated with dsDNA and T histone, making it most common pattern in SLE. Making it most common pattern in SLE, we can say. Second one, if you get the centromere pattern, you can see here, if you look closely, let me try to highlight it for you, right? The centromere pattern, you can see like a circular dots are present, centromere pattern, and then you have to only visualize the spindle formation. The centromere pattern is the spindle formation. You can see they are present in the anticentromere antibody and correspond to CREST syndrome. Yes, at the navel it is present. All these are there in the concept book. I want you to fill up the column, empty column, you can fill it up so that you can remember and revise these points. Anticentromere corresponds to CREST syndrome, limited form of systemic sclerosis. Nucleolar pattern, easiest to identify, like a bifid nucleus. Nucleolar pattern corresponds to anti-topoisomerase, also called SCL70, corresponds to diagnosis of diffuse systemic sclerosis. Diffuse systemic sclerosis will be present, and there is a speckled pattern. Speckled pattern, you can see the pattern, it is staining is there with the speckling. There are dots here there are dots in between, speckled pattern is present, corresponds to SSA, SSB, Sika syndrome, and TU1RNP, MCTD, also seen with antijo, that is polymyositis syndrome. Polymyositis syndrome will be present. So, okay. So what I am going to do, please remember, there will be a video of image review also. Okay. Image review also will be uploaded separately. Okay. That is already pre-recorded. Whatever we are discussing in class will be uploaded as a image review video. ठीक है, अलग से. Because यहाँ पर क्या, we are going to discuss the image along with disease. This is complete video, total video. Complete video will be put up on the group, on your eMedicos app. So don't worry. Images are there in concept book and you can go through the image review video anytime. That will be clear to you. So कहाँ आ गए हम लोग? MBBS तक आ गए. MBBS in rheumatology आ गए. So छोटा सा break लेंगे. So we are going to take the break till the 7:55. आज भी वही हालत है. Break till 7:55. We will take a break. And then we will complete class till 10:30. Class till 10:30 p.m. Okay. Because we want to complete lupus disease, we want to complete the myositis and the overlap syndrome. Okay, with the images, we want to complete. So this is our plan for the day. कल का भी मेरे को बताना. Tell me tomorrow also if it is possible for 4:30. Anna, so just don't stress. Anna, if possible 4:30 को start करेंगे so that we can finish by 9:30 p.m. Anna, so let me know at end of the thing or it will be 5 to 10. Anna, as per our schedule. ये plan हम लोग खुद में आपस में कर लेंगे. ठीक है? So चलिए. So this is our plan. If there are any doubts still here, you can ask me. Otherwise, we will take a break and we will proceed forward. ठीक है? So ये बहुत important है. Physiology of immune system. What are the immune excess disorder? How they present, when to suspect and how to screen. When to suspect, how to screen. We are going to do. है ना? So आराम से देखिए. So this is our classification for the day. This is our classification of rheumatology diseases for the day that we want to study. इसको सब हटा देता हूं अभी यहां से. ग्रेट. चलो अभी ब्रेक ले लो. 7:55 को ज्वाइन करो और 10:30 को भाग जाएंगे आज. राइट. सो वेलकम बैक टू दिस सेशन. So in this session we want to complete our topic of lupus, myositis and overlap syndrome is our target in this topic, right, in this session. Right, so this is the classification once more. So we want to complete the topics which are ANA positive. We want to study about lupus disorder, we want to study about myositis and the overlap syndrome we want to study. So as we saw, the classification is already done. All that we have to do is go through the individual topic. So just me help you with this, that we all of us know the review to physiology. We know the review of physiology. We know the symptoms when to suspect rheumatology disease, and we learnt about ANA testing. And we studied for the classification also. We have studied. So all we have to do now is quickly one by one complete individual disorders. And we know that it is starting from definition, ending with prognosis. Same structure we want to follow, and we will be able to breeze through the topics. Through the topics we will do. Right. So starting with the first topic of this session, the most famous lupus disease is the SLE. Most famous lupus disease is the SLE. In this session, most important. So SLE is the most common lupus disorder. It is the most common lupus disorder affecting the young females of childbearing age group. Most common lupus disease. 1 minute, yaar. Right. So affecting young female. What is the cause, etiology of SLE? The most common cause is the idiopathic. Most common cause is the idiopathic, unknown cause. So unless specified, when we talk of SLE, we are actually talking about idiopathic SLE only. Talking about the idiopathic SLE only. But we must remember that 1 to 5% of the cases may be drug-induced lupus. 1 to 5% of the cases can be drug-induced lupus, that is DIL. So that we have to study separately. First we will write down topics about the content about idiopathic SLE, and then we will compare it with drug-induced lupus. Compare it with the drug-induced lupus. We will compare it. So tell me, the cause is not known, but we have identified few risk factors associated with SLE. Let's write them down. We have identified few risk factors associated with SLE. Let's write about that. Risk factors associated with SLE. What are the risk factors? The risk factors are divided into genetic risk factors, chromosomal defects. The chromosomal defects, infection and toxin exposure, which are associated with increased risk of SLE. The toxin exposure which are associated with increased risk of SLE. So we are dealing with genetic risk factor, chromosomal defects, infection and toxin exposure. Risk factors for associated risk of SLE. Fill the column please. The most common genetic risk factor is the TREX1 gene defect. Most common chromosomal defect is the Klinefelter's syndrome. Most common infection associated with SLE, Epstein-Barr virus. And among the toxin exposure, ultraviolet rays and silicosis can increase risk of SLE. Ultraviolet rays and silicosis can increase the risk of SLE. So we want to know how to suspect SLE. But rather than writing it as clinical feature, I am going to write it under the heading 11 clinical criteria. Rather than writing it as clinical feature, I am going to write it under the heading of 11 clinical criteria, which we are going to use to diagnose the case of SLE. So this 11 clinical criteria are given by the SLIC. We will understand that later. The SLIC has given us 11 clinical criteria along with the 6 immunological criteria for the diagnosis of SLE. for the diagnosis of SLE. So we want to enumerate them one by one. So automatically we will understand when to suspect SLE, when the patient has one or more of the symptom, and what antibody test can we do to confirm the diagnosis we will learn. So the SLIC criteria, full form we will write later, has got two sets of criteria, 11 clinical, 6 immunological criteria. Write them with me. The first clinical feature that comes to our mind when we think of SLE is obviously the malar rash, the classical butterfly rash, which is the acute cutaneous manifestation of the disease. The most characteristic is the presence of malar rash, which is the acute cutaneous manifestation. We also have discoid rash. The patient can also present with discoid rash, which is a chronic cutaneous manifestation. Chronic cutaneous manifestation. But these two cutaneous manifestation, are most typical. These two cutaneous manifestations are most typical of the disease. But are they most common? No, they are present in 30 to 50% cases only. So the skin manifestations of SLE are probably the most famous, most characteristic to reach the diagnosis. But unfortunately, they are present only in 30 to 50% of the cases. So what is the most common symptom that the patient comes with? Most common symptom is the synovitis, which is present in 85% of the cases. Most common feature is the synovitis, which is present in 85% of the cases. You get joint involvement. What is the pattern of joint involvement? Most common pattern is a symmetrical polyarthritis. In SLE, the joint involvement is most commonly symmetrical with involvement of multiple joints, which can lead to deformity, which can cause the deformity, and that is how it can mimics RA. In the early stage of the disease, the joint involvement of SLE can mimic RA. Joint involvement of SLE can mimic RA. But how is the joint involvement different from RA? How is the joint deformity of SLE different from RA? It is both reversible. The deformity is reversible with no bone erosions on the radiology. So how is the SLE different from RA? Pattern is same, but the deformity is reversible with no bone erosion. That is why it is also called as non-erosive arthritis. It is also called as non-erosive arthritis, which is also known as the Jacob's arthropathy. The Jacob's arthropathy is the most common presenting symptom of SLE in general practice. So rheumatologist is going to get a young female who has been referred to you because she was ANA positive. Statistically speaking, most common lupus disease is SLE. So you will start searching for features of SLE. If the rash is present, it is very typical, but in majority they will come with non-erosive arthritis is most common symptom. The patient can also present with oral or nasal ulcer. Patient can also present with oral or nasal ulcer. They can present with non-scarring alopecia. They can present with non-scarring alopecia. They may also present with serositis. They can present with the serositis. Among the serositis, one of them, example, change color to red, is the pericarditis. Why I have made pericarditis red? Because like in uremia, it is one of the life-threatening manifestation. Like in uremia, it is one of the life-threatening manifestation of SLE. But the life-threatening manifestation, most common cause of acute mortality is lupus nephritis. We will be writing the causes of mortality in the end, so don't worry to write it here. Just note down what I am writing is the lupus nephritis. In the CNS, the death can occur due to the neuropsychiatric features. Death can occur due to neuropsychiatric features, can cause death of the patient, where the patient can present with convulsion with or without psychosis. Convulsion with or without psychosis can be the presenting complaint. Can be the presenting complaint. They may also present with features of hemolytic anemia. Present with features of hemolytic anemia, HB less than 10 gram. HB less than 10 gram. They can come with fatigue. Number 10, they can come with leukopenia, which is defined as WBC less than 4000 or lymphocyte count less than 1000. They can come with leukopenia, or they can present as thrombocytopenia, platelet count less than 1 lakh, which can be responsible for the coagulopathy can occur. Can be responsible for coagulopathy can occur. So we have got all 11 here. 11 clinical criteria. So when a young girl comes with multi-system involvement, you must consider differential of SLE. Must consider differential of SLE. But among all the 11 criteria, there are only 4 which are considered life-threatening. There are only 4 which are considered life-threatening features of the disease. So recall with me, what are the 4 life-threatening features in acute SLE? Pericarditis, lupus nephritis, neuropsychiatric manifestation, and coagulopathy can cause death of the patient. Can cause death of the patient is a true statement. So look at this column. First point, we have written the most typical, and second we have written most common, and then we have written the other clinical feature of the disease. The other clinical features of the disease. 1 minute. Yes. So coming to the immunological criteria. Immunological criteria we want to study. So if you suspect patient with SLE, what test should we do? Number one, and why should we do? Number one, we can ask for ANA testing. We can do ANA testing. We can do because it is the most sensitive antibody. But remember, the problem with ANA is that it is not specific of the disease that we studied. So ANA in rheumatology itself can come with multiple groups of disease. So it is not specific for the SLE, though we use it for screening. Number two, then what is most specific? Recall, most specific is the anti-Smith. Most specific is the anti-Smith. But we don't prefer it in practice because it has got only 10% sensitivity. We don't prefer it in practice because it has only 10% sensitivity. We can ask for the most preferred is the anti-dsDNA is most preferred. dsDNA offers both sensitive and specific. It is both sensitive and specific, 60 to 80%. So it is excellent for diagnosis. It is both sensitive and specific, excellent for diagnosis. Along with that, it has got prognostic role also. Prognostic role, write it in blue. How it is prognostic also? Because the titers of dsDNA correlate with the severity of SLE. They correlate with the severity of SLE. And it also predicts increased risk of CNS and renal involvement. So the presence of dsDNA also predicts increased risk of CNS and renal involvement. So I can ask for anti-dsDNA, which plays double role. I can also ask for APLA, anti-phospholipid antibody. Anti-phospholipid antibody also 50 to 60% sensitive and specific. Anti-phospholipid antibody also I can check. Anti-phospholipid antibody also I can check, which also tells me increased risk of thrombosis. Anti-phospholipid associated with risk of thrombosis and recurrent abortion. So cause of recurrent first trimester abortion can be anti-phospholipid antibody syndrome, which can be isolated or it can be part of SLE also. So again, the antibody has role in both diagnosis also, prognosis also. We could have also asked for DCT, that is the direct Coombs test. I can ask for the DCT, the direct Coombs test. But direct Coombs test lacks specificity, less than 30% specific. And number 6, I can ask for serum complement level, which we have written, persistently low C3. Persistently low C3 is specific for diagnosis of SLE, where we have written yesterday under the column of hematuria, approach to hematuria. We have written this point. Approach to the patient of hematuria. We have written this point. So read it together. Immunological criteria are 6 in number. Immunological criteria are 6 in number. So in a clinically suspected case of the SLE, I can ask for ANA, anti-Smith, anti-dsDNA, APLA, DCT and the serum complement level. I can do serum complement level I can ask for. So total मिलके कितने हो गए 11 clinical, 6 immunological criteria are present. So who has given this? SLIC. The SLIC is the systemic lupus. SLIC का full form the systemic lupus international. Systemic lupus international collaborative clinics criteria. Collaborative clinics criteria we are using in practice. Collaborative clinics criteria, the SLIC. So systemic lupus international collaborative clinic criteria we are studying. So out of the total 17 criteria, total how many are there? 17, 11 plus 6, 17 criteria. More than equal to 4 positive confirms SLE. But only condition, there should be at least one of each criteria. One of each means which criteria? One clinical, one immunological. So total there are 17 criteria for diagnosis of SLE. Out of that I want only 4 present to confirm the diagnosis. But the 4 should contain at least one of each criteria. At least one of each criteria. So one should be clinical, one should be immunological. But unfortunately, what is the fallacy with SLIC criteria? The SLIC criteria is very easy to follow. True statement, very easy to follow. However, it has given equal weightage to each criteria. The SLIC criteria has given equal weightage to each criteria. It has given equal weightage to each criteria. But that is not fair, no? Because malar rash is specific. Oral ulcer is not. ANA is sensitive. dsDNA is both. So equal weightage has been given to each criteria. And hence it has decreased specificity. So in order to make it simple, user friendly, what did the SLIC do? The SLIC has compromised on its specificity. By giving equal weightage, it has compromised on its accuracy in an effort to make it user friendly. So it is easy to use, but it is not specific. तो क्या करें? छोड़ देंगे SLIC को? नहीं. SLIC is a good criteria. So we are going to add a patch. How we do? Update patch. What we are going to do? Update the patch. So update the patch. We are going to learn the 2019 EULAR update. The 2019 EULAR update we want to study. The 2019 EULAR update for the diagnosis of SLE we want to study. So the EULAR update said that EULAR update, what it did? It has given score. It has given score to each criteria. It has given score to each criteria based on specificity. So now the EULAR said that I will keep the criteria same, but I am going to give score to each of the criteria. Giving the score to each of the criteria, and if the total score is more than equal to 10, it is confirmatory, confirms the diagnosis. So total score more than 10 can confirm the diagnosis. That is the new update. So rather than counting number of criteria present, each criteria has a score based on the specificity. You don't have to know the exact score, but you can understand that malar rash will have more points than oral ulcer. Whichever is more specific will be given higher weightage. Will be given higher weightage. We can see. Number 2, what it also did, it has made ANA more than 1:80 as an entry or essential criteria. That is essential criteria for diagnosis of SLE. So ANA negative can never be SLE. ANA minimum quantity at least 1:80 should be present. At least 1:80 should be present to qualify for a suspected SLE. Number 3, what it did, it has done, it has taken, it has excluded, added fever. It has added fever to the clinical criteria. It has added fever to the clinical criteria because fever is a common symptom. So it has added fever to the clinical criteria, and it has excluded the DCT from the immunological. It has excluded the DCT from the immunological criteria because DCT lacked specificity. The DCT lacked specificity. That is why it has excluded the DCT from immunological criteria. So what it has become? The EULAR update is now both sensitive and specific. Both sensitive and specific. And specific for diagnosis of SLE. For the diagnosis of SLE, both sensitive and specific for the diagnosis of SLE. It has become both. So SLIC criteria had compromised on its specificity. But the EULAR update, what is EULAR? EULAR is the Avenger, European League Against Rheumatism. EULAR is the European League Against Rheumatism. So European League Against Rheumatism came into picture, and it told us that rather than counting criteria, you let us give a score based on the specificity, and the total score more than 10 confirms the diagnosis. ANA is essential to be positive, fever is added to clinical criteria, and DCT excluded because it was not specific. It was not specific. Anand, so don't worry. Pujita and Ram, I to keep repeating 100 times, so don't worry. एक बार तो revise हो ही जाएगा. So let us read from the start now. SLIC criteria ने क्या बोला? So what we have to see, when you will suspect SLE, when a young female presents with, when you will suspect SLE, when a young female presents with multi-system involvement. Young female comes with multi-system involvement. Think of SLE. So the female can present with malar rash, discoid rash, that is specific. They can come with joint pain, which is common but non-erosive. They can come with oral ulcer. They can come with alopecia. they can come with serositis, they can come with glomerulonephritis, they can come with CNS involvement or hematology involvement. These constitute the 11 clinical criteria by SLIC. 11 clinical criteria, out of which only 4 are life-threatening. Only the 4 are life-threatening. In this suspected patient, we can take the help of 6 immunological criteria. So I will prescribe, as rheumatologist, you will prescribe that in this patient do ANA, do anti-Smith, do anti-dsDNA, do APLA, do DCT, do complement level. So based on the SLIC criteria said that out of this total 17, I want only 4 positive, then diagnosis is confirmed. But at least one of it must be clinical, at least one must be immunological. One clinical, one immunological can confirm diagnosis of the disease. Diagnosis of the disease, right? Clear? So Pujita, I hope this is clear now. Very simple. So we have to diagnose this. It's a simple system. But what I have said, since it gave equal weightage to each criteria, it has got reduced specificity. But to overcome that obstacle, we have adopted the Euler criteria. So new one, update, we have adopted the Euler criteria. We have gone to, because the SLIC was not specific enough. So what did Euler do? Euler maintained the same points. Euler maintained the same point, but it has given score to each criteria. And now we want only score of 10 to confirm the diagnosis. ANA is compulsory. Fever can be used for diagnosis. DCT cannot be used for diagnosis. And Euler has now become both sensitive and specific for diagnosis. So SLE must know topic, because it is very common in both practice and MCQ. So you must know specific and sensitive for diagnosis is Euler scoring system. Go to the next page. Once confirmed, you also want to know which are the prognostic only antibodies. Which are the prognostic only antibodies in a confirmed case of SLE. In a confirmed case of SLE, which are the prognostic only antibodies? Because from the SLIC criteria you saw, there are 2 antibodies which are playing double role. They are both diagnostic also, prognostic also. So which are the 2? Diagnostic also, prognostic also. From the SLIC criteria we saw. From the immunological criteria, there are 2 anti-dsDNA and APLA which are diagnostic also and prognostic also in SLE. But now we want to know about those antibodies which only tell me outcome of disease. Only tell me outcome of the disease. In confirmed SLE, I can ask for anti-Rho and anti-La, because the problem is anti-Rho can cross the placenta. The anti-Rho can cross the placenta and hence associated with increased risk of congenital SLE. So if a SLE patient comes with pregnancy or wants to know whether if she gets pregnant, what is risk to the child, I will prescribe for her anti-Rho, anti-La antibody. If they are positive, then I will tell her that the pregnancy can be complicated for the child. Child can get a congenital SLE. I can also check for anti-ribosomal P. I can check for anti-ribosomal P, anti-neuronal antibody. Both are associated with increased risk of CNS involvement. Associated with risk of CNS involvement, they are present. We can also ask for antiplatelet antibody. Antiplatelet antibody associated with increased risk of coagulopathy. Increased risk of coagulopathy we can see, and that is how they tell me outcome of the disease. So these are prognostic only antibodies in a confirmed case of SLE. Once the diagnosis is done, proceed to the treatment. The management of acute SLE. The management of acute SLE, we know the drug of choice is steroids. Pharmacology, we know drug of choice is steroids. But how to use the steroid, whether to give IV, whether to give oral, will depend on the presence of life-threatening feature. Will depend on the presence or absence of life-threatening features of SLE. So tell me, so based on the life-threatening feature present or absent, I am going to divide acute SLE patient into two. I am going to divide acute SLE patient into two. Drug of choice is steroid. I am going to divide acute SLE patient into two groups. If any life-threatening feature is present, I am going to label the patient as suffering from autoimmune crisis. I am going to label the patient as suffering from autoimmune crisis. If the patient has got no life-threatening feature, I am going to label them as mild SLE flare. So we have already written which are life-threatening feature, already written. If any one is present and we get autoimmune crisis, the drug of choice is IV methylprednisolone. The drug of choice is IV methylprednisolone. What is the dose we give? Methylprednisolone. I give it under dose of 1 gram per day. 1 gram per day for 3 to 5 days I am going to give. This is called as pulse therapy. So every day single injection I am going to pulse 1, 1, 1 and I am going to destroy the T cell. So steroids basically target the T cell. They are going to suppress the T cell. So in autoimmune crisis, drug of choice is IV methylprednisolone. But in mild flare, I don't have to give IV. I can start with oral prednisolone. I can start with the oral prednisolone. Dose 1 to 2 milligram per kg per day. I can start with oral prednisolone. I can give this patient. Oral prednisolone I can give this patient. But what is the challenge here? So I am going to start patient on oral prednisolone in a mild flare. So this is drug of choice only, not treatment protocol. Take it forward. If the autoimmune crisis comes, you have given IV prednisolone, patient settles down, you continue with oral prednisolone. After IV is over, if the patient improves, you continue with oral prednisolone. But what if they don't improve? What if they don't improve? That means What will be the treatment in refractory cases? What if they don't improve after giving IV steroids also? Then what comes next? In refractory cases, the next level, I want to start the patient on IVIG versus plasmapheresis. What does IVIG do? It is antibody against the antibody. So more specifically, the patient's blood contains auto-antibody. When I give them infusion of intravenous immunoglobulin, I am giving neutralizing all circulating antibody. Or I can give plasmapheresis, also called plasma exchange. What does it do? It filters the antibody. So by removing the plasma from the body, you are removing the antibody from the patient and giving them relief of inflammation. You are providing relief of the inflammation can be given. So methylprednisolone, drug of choice. But if it does not work, the next choice is IVIG versus plasmapheresis. Specifically for SLE crisis alone, I have also got for SLE crisis alone, I have got some approved anti-B cell agent. I have got approved anti-B cell agents. I have got it approved only for SLE crisis. So other treatment can be done in any autoimmune crisis. But for SLE crisis alone, I have got two anti-B cell agent. Recall first session. They are the monoclonal antibody. Against monoclonal antibodies are also called biologicals. They are derived from live cell culture. They are the biologicals against CD20 or the BAF. CD20 or the BAF. I can give, yes, CD20 or the BAF I can give. So anti-B cell therapy includes both rituximab or I have got belimumab. So what you want to give is your choice based on availability of the drug. Based on the availability and the cost maybe, you will start the patient on treatment. In India, rituximab is readily available and because of management in lymphoma, we have got adequate trials on its safety also. So I would personally prefer rituximab if a patient of autoimmune crisis does not respond to IV steroid. I would prefer to give them IV rituximab to induce remission. Listen to the word, to induce remission. After the patient has improved, I continue with oral prednisolone. But we know oral prednisolone is having plenty of side effects. So along with that, I always add the steroid sparing agent. I am going to add a steroid sparing agent from day 1 of therapy. Why day 1? पहले steroid हो जाने दो ना, after that हम ये देते हैं. Why to give it from day 1? Because steroid sparing agent, the minimum time for onset of action is 6 weeks. So that is why from the day 1 I am going to start the patient on steroid sparing agent and then only I can taper the steroids. then only I can taper the steroids after 6 to 8 weeks. So once the action of steroid sparing agent has come, then I can taper and stop the steroid. Taper and stop the steroid. Only I will continue steroid sparing agent. So among the steroid sparing agent, same color use करते, steroid sparing agent, which is the safest and the most preferred steroid sparing agent in SLE. Most preferred steroid sparing agent in SLE is the hydroxychloroquine. Write short form and keep HCQ. So the most safest, most preferred steroid sparing agent in SLE is hydroxychloroquine, which is the potent alternative. Potent alternative is to consider MMF. Mycophenolate mofetil. The MMF, mycophenolate mofetil, needs to be considered. As I told you, the problem is the cost. Mycophenolate mofetil is expensive. Steroid sparing agents are just immunosuppressive agents. Other immunosuppressive agent, that is called as steroid sparing agent. Immunosuppression they will do. So for chronic prophylaxis, I can prefer the steroid sparing agent in contrast to the steroid itself. Because what's the problem with SLE? Unfortunately, there is no cure in SLE. So patient is on lifelong immunosuppression. The patient is on lifelong immunosuppression, which comes at a high cost and high adverse drug reaction of the therapy. So steroid sparing agent ka minimum time is 6 weeks na. So you have to give it from day 1, so that in 6 weeks their action will start. Then you taper off the steroid. Then only you can taper the steroid. So along with the steroid, you are going to start patient on HCQ. After 6 weeks, you are going to stop the steroid. Only continue HCQ, or you continue mycophenolate mofetil. You want to continue, right? So problems with the treatment, there is no cure, lifelong immunosuppression, high cost and adverse drug reaction of therapy is present. There is also high mortality in SLE. So what are the mortality causes in SLE? We want to know. What are the causes of death in a patient of SLE? We want to know. The causes of death divided into the presentation. Acute mortality during acute SLE flare. The cause of death during acute SLE flare, and in a patient with chronic long-term disease. SLE. 1 minute, please. Yeah. Yeah. So what are the causes of death? So in acute SLE flare, most common cause of death is the renal failure that we have written. Most common cause of death is the renal failure, followed by the neuropsychiatric features, the neurological feature, followed by coagulopathy, and followed by pericarditis. That's what we have written. So in acute, the most common cause is renal failure. But in chronic long-term disease, what can be the problem? In the chronic long-term disease, the most common cause of death is the heart failure. Most common cause of death is the heart failure. Is most common cause of death is heart failure. Why heart failure? Overall, most common cause. Overall, most common cause is also heart failure because SLE is a procoagulant, prothrombotic state. Prothrombotic state leading to risk of thrombosis and inflammation. And the inflammation damages the vascular endothelium. The inflammation damages the vascular endothelium, predisposing to increased risk of atherosclerosis. So the cause of death is most commonly we want to do. We want to damage the inflammation, damages vascular endothelium, increased risk of atherosclerosis. So the problem here is even if you control the disease, the prothrombotic state and atherosclerosis can contribute to mortality and also the risk of opportunistic infection. The risk of opportunistic infection due to immunosuppression. Due to immunosuppression. So due to immunosuppression. So overall prognosis of SLE is poor prognosis. Overall prognosis of SLE is a poor prognosis. Because what are the points we are having? There is no cure to the disease. There is no cure to the disease. No cure to the disease, lifelong immunosuppression, high cost of therapy, high adverse reaction and high mortality. High mortality in SLE is going to be poor prognosis. That's why we say poor prognosis, we can say. Poor prognosis, we can say. Now remember this, Anshika. So what is the reason? What is the reason? Yaad rakhna. So why we are being this? So kaisa hai? Steroid. So along with the immunosuppression. Along with the immunosuppression. If you continue long-term use, what happens? Long-term use causes HPA suppression. The hypothalamo-pituitary axis suppression leading to dependence. ये नहीं चाहिए ना बेटा. So problem is here. This is what is prevented when you give steroid sparing agent. When you give the steroid sparing agent. When you give the steroid sparing agent, they only cause immunosuppression. They only cause immunosuppression. No HPA suppression. No HPA suppression. That is why they are preferred for long-term use. That is why they are preferred for long-term prophylaxis. Preferred for the long-term use. You can give. Okay, long-term use, you can prefer them. So understand again now. So the point here is that SLE is unfortunately not a good disease to have. SLE unfortunately not a good disease to have because there is no cure. Even though we have adequate knowledge about the disease, the treatment is full of side effect and there is high risk of mortality in the patient. High risk of mortality in the patient is there, right? So this is idiopathic SLE for you. But SLE is not done because dil baki hai. Drug induced lupus. Drug induced lupus, when to suspect? When a patient comes with features of SLE, but the patient has 2 or more month intake of potentially offending drug use. 2 or more month use of the potentially offending drug. Of the potentially offending drug. Potentially offending drug use is present. So which are the drugs causing SLE? Tell me, which are the drugs causing SLE? So when the patient comes with the features of SLE, when patient comes with the features of SLE, with 2 or more month use of potentially offending drug, then you will suspect SLE, drug induced lupus. That time you will suspect drug induced lupus. You will suspect. So which are the drugs which cause SHIP? Very good. A SHIP कैसे खत्म हो गया अभी? SHIP has sailed. So what is the point? Please remember, the SHIP has sailed. ये क्या outdated knowledge है? The ship has sailed. Outdated knowledge. So please remember, thoda sa update kar le. Outdated knowledge. So what are the new drugs we must know? ये ship को क्या छोड़ देते है ना? So hey, it is useful I know to remember in Viva, but not useful in practice. So the most common offending drug remains cardiovascular agents. So most common offending drug remains the cardiovascular agents. Cardiovascular agents. And there are antibiotics. So the common culprits are the cardiovascular agent, which include ACE inhibitor, beta blocker, thiazides, statins and alpha-methyl dopa. Which are still commonly used. But SHIP में क्या था? Hydralazine. कोई use नहीं करता ना hydralazine. It is replaced by the labetalol now. And there was SHIP contains procainamide. वो भी कोई use नहीं करता. SHIP contains procainamide, which was considered most toxic among this entire list, but it is no longer used in practice. तो SHIP में था sulfonamide, नहीं यूज करते. Hydralazine, isoniazid, procainamide. चलो isoniazid we give. So isoniazid anti-TB drug, dapsone and sulfonamides are present, which can potentially cause drug-induced lupus. Yes, Madhvi, you are right. Mechanism. One of the mechanism is acetylation. But this drug list is now expanding. So common problem is still with the cardiovascular drug and antibiotic use can cause drug-induced lupus. Beyond that, we will also take history of CNS agent. Which CNS agents are there? Phenytoin sodium and carbamazepine. Phenytoin sodium and carbamazepine can cause the problem. Today my dog is really active. Today? Sorry. Yeah. So we have got endocrine drug. We have got propyl thiouracil. The propyl thiouracil is present. There is GIT drug, that is proton pump inhibitor, sulfasalazine. Proton pump inhibitor sulfasalazine can cause problem, and miscellaneous agent D-penicillamine, and the D-penicillamine is there, right? So this is our important point. Okay, so rare causes of the drug-induced lupus we want to write. Drug-induced lupus we want to write. So एक बार ये लिस्ट बना देते हैं. So drug-induced lupus is suspected when the patient has features of SLE but has contained 2 or more month use of potentially offending drug. 2 or more month history of potentially offending drug is present. So what are the differences from idiopathic SLE? Let's write down differences from idiopathic SLE. The drug-induced lupus affects both genders equally. It affects both genders equally. Males equal to females. It affects both genders equally. Males equal to female. Unlike idiopathic SLE. Unlike idiopathic SLE is going to be there. Number 2. But there is a risk of the renal and CNS involvement. The risk of renal and CNS involvement is very, very low. That is good news, because these were the dreaded complication in idiopathic SLE. But risk of the renal and CNS involvement is low. Why? Because majority are anti-dsDNA negative, which is responsible for lupus, and have normal C3 level, means disease activity is low. So renal involvement does not occur and disease activity low. So complications are low as compared to drug-induced lupus. So what antibody we will check for diagnosis? Antihistone positive, both 60 to 80%, sensitive and specific. Sensitive and specific for drug-induced lupus is the antihistone antibody. The only treatment is to stop the drug. which offers potential cure, making the prognosis good prognosis. Making the prognosis good in majority. Making the prognosis good in the majority. But what we must remember, always in MCQ, एग्जामिनर कैसे होते हैं? नंबर 1 कमीना. वो कैसा? ही डज नॉट वांट गुड प्रोग्नोसिस. वो कह रहा है कि मरेगा कब वो बताना. सो वी वांट गुड प्रोग्नोसिस. एक्सेप्शंस. What are the exceptions when the prognosis is not good? Prognosis is not good when the patient has drug-induced lupus following anti-TNF alpha agent use or interferon use. Can also cause drug-induced lupus. These are rare causes. These are rare causes of DIL. These are rare causes of DIL, but they are potentially fatal. But they are potentially fatal because they can cause renal failure. Because they can cause renal failure. That is why they are exception to the rule. Exception to the rule. So drug-induced lupus as a group has got good prognosis because here, unlike idiopathic SLE, you can cure the disease by stopping the drug. Cure the disease by stopping the drug. But if it occurs after use of anti-TNF alpha or if the patient develops after interferon use, then they can be potentially fatal. So that time you call it as the exception to the rule. So we got the steps here of drug-induced lupus. We have got it here. So Ram, hypersensitivity is not the right word. Age of DIL is what? Autoimmunity. So mechanisms are different and an exact mechanism we don't know and it is rare problem, right? So I don't know, so we'll keep that pending. So classification. So we completed our first disease of the session in detail. So everybody clear with SLE? If the young female comes with ANA positive in significant titer, statistically, most common diagnosis is SLE. SLE is diagnosed using SLIC criteria or the Euler update. Drug of choice for acute attack is steroid, but then you continue steroid sparing agent for lifelong immunosuppression. There is no cure, high mortality, hence poor prognosis is what we have written. Come to second cause, that is scleroderma or systemic sclerosis. Second lupus disease. The second lupus disease is the scleroderma, which is now called as the systemic sclerosis. The scleroderma, which is now called as systemic sclerosis. SSC, short form लिखेंगे. Called as the systemic sclerosis, that is SSC, short form we will write. So first question to all of you, कि नाम क्यों बदला? Why to change the name scleroderma? Because the word scleroderma means fibrosis of the skin. The word scleroderma literally means fibrosis of the skin. जबकि more than 98% cases have organ involvement. So the name scleroderma underestimates the severity of the disease. It underestimates the severity of the disease. The scleroderma सुनने में कैसा लगता है? It is called as cosmetic. चमड़ी की बीमारी लगती है. Looks like a skin problem, but actually it's not a skin problem. So the better word is to call it as systemic sclerosis. is the preferred name. We still continue to use scleroderma because we are known to it, but here we want to know. So we know that here systemic sclerosis is present. Systemic sclerosis is present. That is the better name that we must know. When to suspect the disease? Epidemiology, 30 to 50 years, female dominant disease. Epidemiology, 30 to 50 years, female dominant disease is scleroderma. Here also the cause is idiopathic, like SLE. The cause is idiopathic. But like SLE, we have got risk factors. Like SLE, we have got risk factors for development of the disease. Development of the disease. Development of the disease. So risk factor includes risk factor for systemic sclerosis include parvo B19 infection, cytomegalovirus infection, and silicosis. The cytomegalovirus infection and silicosis is to be done. Is to be risk factor for the disease. Risk factor for scleroderma. What are the clinical features? What are the clinical features of the disease? What are the clinical features of the disease? Clinical feature, the most common and the earliest feature. The most common and the earliest feature of scleroderma, systemic sclerosis, is the Raynaud's phenomenon. So even though the name was scleroderma, the most common problem is Raynaud's phenomenon. Why? Because Raynaud's can precede. It precedes the skin changes by almost a decade, more than 10 years. It precedes the skin changes by more than a decade. That is the word. By more than a decade, it is going to cover. It is going to cover. Precedes the skin changes with more than 10 years. It is going to cover. Raynaud's phenomena, है ना? रुको ना, बहुत से आप लोग डाउट्स डाल रहे हो, उससे ना माइंड डिस्ट्रैक्ट हो रहा है ना. एक मिनट, लेट मी रीफोकस, है ना. सो क्या ये सब जो है ना टॉपिक्स जो है निखिल एंड मानसा एंड अंशिका, है ना, प्लीज रिमेम्बर है ना, इम्पोर्टेंट मैं कवर करूंगा. ये सब कैसे स्किन में भी ओवरलैप होगा. स्किन में यू विल स्टडी अबाउट डिस्कॉइड ल्यूपस एरिथेमेटोसिस, है ना. सो इन पैथोलॉजी यू स्टडी द टाइप्स ऑफ ल्यूपस नेफ्राइटिस. टाइप्स ऑफ ल्यूपस नेफ्राइटिस यू विल स्टडी, बट वो फर्क नहीं पड़ता. ट्रीटमेंट तो हमने पढ़ लिया, आरपीजीएन है क्या है, अकॉर्डिंगली हमें ट्रीट करना है. ठीक है. सो डोंट वरी. अंशिका, क्रॉनिक ऐसा कुछ नहीं होता है बेटा, है ना. तो माइल्ड फ्लेयर नहीं है, वो तो एक कंटिन्यूम है ना. द ट्रीटमेंट इज अ कंटिन्यूम, है ना. तो अक्यूट फ्लेयर आया, हमने ट्रीटमेंट स्टार्ट किया, वापस से फ्लेयर आया तो सेकेंड फ्लेयर काउंट करने का, फ्लेयर में देखने का लाइफ थ्रेटनिंग है कि नहीं है. लाइफ थ्रेटनिंग है तो वापस स्टीरॉइड देने का और अपग्रेड करते रहने का, है ना. सो दैट यू विल हैव टू कंटिन्यू द ट्रीटमेंट. सो कमिंग बैक, है ना, लेट्स फोकस. लेट्स नॉट गेट डाइवर्टेड. डिस्ट्रैक्ट हो रहे आप लोग, डिस्ट्रैक्ट मत होइए प्लीज, है ना. थोड़ा सा फोकस रखिए, है ना. आई एम कवरिंग वॉट एवर इज रेलेवेंट टू यू, डोंट वरी, है ना. बट डोंट गेट डिस्ट्रैक्टेड बिकॉज इट ब्रेक्स द फ्लो. यू विल ओनली गेट स्ट्रेस्ड अबाउट दिस टॉपिक. सो फ्लो में रखिए, इसको पहले होने दो ना, अपन डिटेल पढ़ते जा रहे हैं. सो देयर इज रेनॉल्ड्स फिनोमिना कैन अकर which precedes the skin changes by more than 10 years. But when patient comes with Raynaud's phenomena, 70% of the cases are idiopathic and self-limiting. So Raynaud's phenomena occurs in a adolescent female. Raynaud's occurs in a adolescent female. It will occur, right? 70% are going to be self-limiting. After few months चले जाते हैं. But 30% of the cases may be associated with autoimmunity. May be associated with the autoimmunity which you want to document. We can be associated with the autoimmunity which we want to document. इसको mark करना number 1. So when the young girl presents to your clinic with Raynaud's phenomena, what is compulsory? You must check for ANA testing. You must check for the ANA testing must be performed. ANA testing must be performed. Right? ANA testing must be performed. If it is positive, you want to document autoimmunity and tell the patient that the Raynaud's is just a symptom, but you may have a tendency to develop autoimmune disease in the future. Because skin involvement कब आता है? 10 साल बाद. So you have to tell her that if you get any new symptom, please report back to me. And till that time, you can give palliative therapy for Raynaud's phenomena. For palliative therapy, the drug of choice is calcium channel blocker. So to control the vasospasm, you want to give vasodilator. To control the vasospasm, you want to give vasodilator, calcium channel blocker. You want to prescribe. Calcium channel blocker you will prescribe. But side effect, calcium channel blocker can cause reduction in the blood pressure. Reduction in the blood pressure because young girl, she is not hypertensive. So she may not tolerate. So we have got iloprost as the approved alternative. It is the nasal spray preparation. It is the nasal spray preparation of a prostacyclin analog. So this also can be used as an alternative to calcium channel blocker. So young female adolescent girl comes to you with Raynaud's phenomena. Along with giving palliative therapy, I will check whether ANA is present or absent. If it is absent, I will reassure her that this is idiopathic and it will disappear, forget about it. But if it is associated with ANA, I will document the autoimmunity. Document the autoimmunity. And I want to also tell her to follow up if she gets any new symptom. If any new symptom is there. Which calcium channel blocker? Nifedipine. Nifedipine. We give short acting calcium channel blocker. Nifedipine can be given. Right? Next symptom. They can also present with the skin changes. So skin changes तो होना चाहिए ना. Scleroderma, systemic sclerosis बोलने के लिए skin changes have to be present. So when the patient develops skin changes, mark it as number 2. You tell her to follow up in the clinic. So you tell her to watch out for the skin changes in the future. So what are the skin changes that she is likely to develop after many years? In the early stages of the disease, she can develop edema. She can develop edema over the face and the extremities. She can develop the edema over the face and the extremities, which is unfortunately non-specific for diagnosis. So I am going to tell her that after you have got ANA positive, I will tell her to watch for the skin involvement. which in the early stage can be just in the form of edema over the face and the extremity can be present. It is only in the late stages of the disease where they present with the specific feature, where they can come with the specific skin features of the disease can occur late in the disease. Late in the disease, you cannot give on a specific features you want to see. Most specific feature is the shortening of the digits. Shortening of the finger is the most specific feature of systemic sclerosis. This feature occurs due to the autoresorption. It occurs due to autoresorption of the terminal phalanx. Due to ischemia, due to capillary involvement, that is called as the microangiopathy. The capillaries of the phalanx are involved. This is called as microangiopathy. Mark it as number 3. Microangiopathy. Mark it as number 3. Microangiopathy is present. So here the patient is going to have the capillary, the distal blood supply to the bone is compromised, and that is why the bone can become shrink. The bone can be auto-resorbed. Leading to the shortening. This is called as a feature of microangiopathy. They can also present with mask-like face. And the fish mouth appearance. Mask-like face and the fish mouth appearance can be there, but these are all late features of the disease. So if you diagnose early, what can you give to slow the progression? You can start the patient on D-penicillamine. The D-penicillamine has got anti-fibrotic action, and hence it slows the progression of the skin changes. We can say. So when a young female comes with Raynaud's phenomena during her college time, adolescent, you have to mark for autoimmunity. When she develops skin changes, you have to document microangiopathy. 1, 2 and 3 present confirms diagnosis of scleroderma. So for diagnosis, what is necessary? For diagnosis of the disease, for autoimmunity, match the number 1. For autoimmunity, you want to perform ANA screening. ANA screening is positive along with the skin changes. Then you have to document the microangiopathy to confirm the diagnosis. So you document the microangiopathy to confirm the diagnosis of scleroderma. So 1 plus 2 plus 3 has to be present for diagnosis to be confirmed. ANA testing we have studied. Skin changes we know. It is a clinical checking. But how to document microangiopathy? For microangiopathy, the nail fold capillaroscopy. The nail fold capillaroscopy is a sensitive test. To detect the microangiopathy. So we have to do that. To detect the microangiopathy. It is a sensitive test. So when the patient of the ANA positive patient comes to you with skin changes, I will think of systemic sclerosis. But to confirm, I need to document microangiopathy using nail fold capillaroscopy. So you have to write the stages for MCQ. In the stage 1, that is early stage of the disease, the only abnormality is the dilated capillary. The only abnormalities are dilated capillaries with normal density and normal villus architecture. Normal villus architecture of the capillary can be seen in the early stages. In the stage 2, also known as active stage, you will find that there is decreased density of the capillary. There is decreased density of the capillary, but there is preserved architecture. I'll show you the picture. First you write it down. And in stage 3, which is the late stages, you are going to get distorted architecture. You are going to get distorted architecture with dropout area. Distorted architecture with dropout areas of ischemia. So areas of ischemia, there is no capillary at all. That will be final stage of the angiopathy. And that is when the late feature will occur. But diagnosis has to be made early to prevent the problem. Diagnosis should be made early to prevent the problem. So remember again, when young female comes with Raynaud's, you will document ANA positive and tell her to come back when she has any new skin problem. If she develops a skin change, you will send her for nail fold capillaroscopy. If it can confirm microangiopathy, your diagnosis is confirmed that it is systemic sclerosis. Diagnosis confirmed that it is systemic sclerosis. But job is not done because we have to further identify the types of systemic sclerosis. We have to divide the systemic sclerosis patient into the types. Which are the types we have got? Limited form of systemic sclerosis. Small column. Limited form of systemic sclerosis. And the diffuse form of systemic sclerosis is present. Two types are there. So after confirming patient has got systemic sclerosis, your job is not over. You have to evaluate further to know whether it is limited form or diffuse form. You have to evaluate further to identify whether it is limited or diffuse form. How to identify? Based on the extent of the skin involved. Based on the extent of the skin involved and based on the associated features present. Based on the associated feature present, you will try to guess whether it is clinically limited or diffuse form. So till now whatever we have written is totally common to both types. Now we want to know whether it is limited or diffuse form. Limited form you will suspect when the skin involvement is restricted to the face and distal to the elbows. It is restricted to the face and distal to the elbow. What is another name for limited systemic sclerosis we have written? CREST syndrome. They are also called as CREST syndrome. What are components of CREST? C for calcinosis, R for Raynaud's phenomena, E for esophageal dysmotility. There is sclerodactyly and there is telangiectasia. That is why limited systemic sclerosis, also called as CREST syndrome. It is also called as CREST syndrome. So you can see that limited form presents with predominantly cutaneous symptom. So predominantly most features of limited form are cutaneous, means relatively mild disease. Skin problem does not cause death, no? So relatively milder, except for liver involvement. Which is more common in the limited form. So only organ more common in the limited form, which is more common affected in the limited form. Of systemic sclerosis, because 10% cases are associated with primary biliary cirrhosis. 10% are associated with the primary biliary cirrhosis. They are associated with. So what you will do? You will ask for specific antibody testing to confirm the diagnosis. Which is the specific antibody for limited form? Remember the table. For limited form, specific antibody is anti-centromere antibody. Immunofluorescence pattern we have studied in MBBS. ANA by immunofluorescence. Centromere pattern has centromere antibody positive, which is specific for diagnosis of the limited systemic sclerosis, which is also called as CREST syndrome. Please remember, the symptoms are usually cutaneous except for the liver involvement, which is the most commonly affected in limited form as opposed to diffuse form. So when will you suspect diffuse form of the disease? You will consider diffuse form of the disease when to consider. So diffuse form of the disease is considered when the skin involvement extends proximal to the elbow. With trunk involvement. And it is right to say that there is increased risk of organ involvement. As compared to the limited form. So except for liver, other organ involvement always more common with diffuse form except liver. Except the liver. Increased risk of organ involvement is present. Which organ can be affected? Lungs can be involved. Which is the most common type of interstitial lung disease? Lung disease in autoimmune disease. Come on, give me answer. Make small column. Answer and small column. Most common type of interstitial lung disease associated with autoimmune disease is the non-specific interstitial pneumonia. The non-specific interstitial pneumonia, that is NSIP. So lung involvement, please remember, most common type of ILD, interstitial lung disease in a autoimmune disease is NSIP, which is responsive to steroids. So you will have to give steroids, NSIP. But the dreaded complication which can cause death of the patient is the pulmonary arterial hypertension. Dreaded because it is most common cause of death, most common cause of mortality. Pulmonary hypertension. Drug of choice is iloprost. Drug of choice is iloprost. Death can also occur due to renal involvement. Renal involvement can occur in the form of GN. Form of GN which can lead to RPGN, which can be prevented by ACE inhibitor therapy. So it can be prevented by ACE inhibitor therapy. And they can also affect the nerve. Mononeuritis multiplex. Short form लिख के रखेंगे. The mononeuritis multiplex. The mononeuritis multiplex is present, which is clinically given as asymmetrical neuropathy, which will be written in the MCQ as asymmetrical neuropathy, which also responds to steroids. Which also responds to the steroid, we can say. But complete the point here for me. This mononeuritis multiplex or asymmetrical neuropathy. Tell me, what are the causes? What are the causes that I want you to know? The most common overall cause. The most common overall cause of mononeuritis multiplex is diabetes. Most common infective cause of mononeuritis multiplex is leprosy. And the most common autoimmune disease causing the neuropathy is PAN. Polyarteritis nodosa. Is the polyarteritis nodosa. Right? That is vasculitis syndrome. So in diffuse systemic sclerosis, this is the table in front of you. So once you confirm the patient has got the systemic sclerosis, you have confirmed the patient has got systemic sclerosis. You can confirm when the patient has got ANA positive, skin changes are present with microangiopathy, 3 feature present, diagnosis complete. But based on the extent of skin involvement, associated feature present and the specific antibody present, you can identify the type of systemic sclerosis. So which is the specific antibody in diffuse type? Is the anti-SCL70. positive. Anti-SCL70 positive confirms the disease. So tell me, what is the prognostic antibody in systemic sclerosis? The prognostic antibody is anti-U3RNP, also called as anti-fibrillin antibody, because it is associated with increased risk of RPGN and pulmonary arterial hypertension. So we want to know prognostic antibody, like we did in SLE. Prognostic antibody. Prognostic antibody we want to know. Right? We want to know the prognosis also. So what is the treatment? There is no cure in the disease. However, there is relatively lower mortality as compared to SLE. So I am going to give this unfavorable prognosis. So compared to SLE, it has got less mortality. But unfortunately, in systemic sclerosis also, there is no cure. In systemic sclerosis also, there is no cure in this patient. That is why prognosis is going to be unfavorable. But you can see, when have you given the steroid? When there is an organ involvement. When patient has got lung, when patient has got nerve involvement, you want to give steroid. Inflammation control. But as long as the symptoms are cutaneous, not life-threatening, you don't give steroid. You give only palliative treatment. You give only temporary treatment is what we know. Right? So this is our second topic done. That is our systemic sclerosis. So bringing us to third topic in lupus disease is the Sicca syndrome. Come on, let's pick up the pace a little. Sicca syndrome. So Sicca syndrome, basically in Sicca syndrome, most common as well as the characteristic feature, both are the same. Most common as well as the characteristic feature is the dryness of the eyes and dryness of the mouth. The dryness of the eyes and dryness of the mouth is the most common as well as characteristic feature of the disease. Characteristic feature of the disease is dryness of eyes, dryness of mouth. Why does the symptom occur? Why do this symptom occur? We must know why do the symptom occur. This dryness occurs due to the chronic lymphocytic infiltration. It occurs due to the chronic lymphocytic infiltration of the exocrine gland, which are namely the lacrimal glands and the salivary glands. The lacrimal glands and the salivary glands are affected in the disease. So Sicca syndrome is typically suspected when the patient comes with dryness of eyes, dryness of mouth, because the most common site of the disease is exocrine gland. But just because patient has come with symptom, don't believe them. You have to test. So what are the tests we can do to confirm the exocrine gland involvement? What test can we do to confirm the exocrine gland involvement? which is most common site in Sicca syndrome. Most common organ affected in the Sicca syndrome. So exocrine glands are most common organ affected, organ involved in Sicca syndrome. So you have to confirm the involvement. What test do we have for lacrimal function? Two tests. We can go for Skimmer's test also, Rose Bengal test also. Skimmer's test and the Rose Bengal test. Salivary test is done by iontophoresis. Please don't worry, this is an obsolete test. Nobody does this. Iontophoresis is electrical stimulation of the parotid. Nobody does it because Skimmer's test is easy to perform and easy to confirm. Once confirmed, the treatment at this stage is palliative only because there is no risk to life, no? So right now you don't want to give any steroid. At this stage, the treatment is palliative only and we will evaluate the patient. For lacrimal gland involvement, I am going to prescribe methyl cellulose artificial tear, methyl cellulose eye drops, and for dryness of mouth, I encourage hydration. I am going to encourage hydration. So simple point, when patient comes with Sicca symptom, first I will confirm that exocrine gland is involved and start the patient on methyl cellulose eye drops, same as artificial tears, and hydration will be given. What is the epidemiology? Commonly, what age group do you get in Sicca syndrome? 30 to 50, female dominant disease is Sicca syndrome. But before you refer the Sicca to rheumatology, what we have to do? Number one, we have to exclude HIV, hepatitis B, hepatitis C infection, which can mimic the Sicca. Syndrome. So you will exclude chronic infection. Chronic infection can also affect the exocrine gland. So you have to exclude that infection and perform ANA screening. The ANA screening, if it is positive, it confirms autoimmune cause, correct? It confirms autoimmune cause, and that is called as Sicca syndrome. So all patients with dryness of eyes and dryness of mouth, please remember, are not Sicca syndrome. Few of them are going to be local causes. Few are going to be chronic infection. After you exclude them and ANA is positive, you can say that this is Sicca syndrome. But this Sicca syndrome is divided into two based on the presence of secondary or associated autoimmune disease. Presence of the associated autoimmune disease we want to search for. So you want to look for secondary causes, that is associated autoimmune disease. Which other autoimmune disease can also affect exocrine gland? Answer is SLE can affect, systemic sclerosis can affect, MCTD can affect, RA and vasculitis can involve the exocrine gland. It can also be affected in primary biliary cirrhosis. primary biliary cirrhosis, and autoimmune hepatitis. And the autoimmune hepatitis, it's going to be present. So exocrine gland involvement can be secondary to associated autoimmune also, or could be primary. So based on the associated disease, in majority one of the associated defect is present, suggesting that Zika is only a part of the associated disease, not the main problem. So we call it as secondary Zika. Secondary Zika, which is more common in rheumatology clinic. More common in rheumatology clinic. But if no secondary causes are found, that means Zika is the disease. That means Zika is the disease, and you call it as the primary Zika syndrome, which is relatively rare. Primary Zika is relatively rare. Understand and right? So when a middle-aged lady presents to your clinic with dryness of eyes, dryness of the mouth, फर्स्ट रेफरेंस किसको करेंगे बताइए? मेडिसिन ओपीडी में हु हैज कम, यंग टू मिडिल एज्ड फीमेल, कम्स विद ड्राइनेस ऑफ आईज, ड्राइनेस ऑफ माउथ, किसको रेफर करेंगे? फर्स्ट यू विल रेफर टू द ऑफ्थेल्मोलॉजिस्ट टू कंफर्म ग्लैंड इन्वॉल्वमेंट. First you will refer to ophthalmologist to confirm gland involvement. After that you will exclude infective causes of exocrine gland involvement. After excluding infection, you will perform ANA screening, and if positive you will say autoimmune cause and refer to rheumatologist. What the rheumatologist will do? Divide the patients of Zika into two, whether they are primary Zika or secondary Zika. How does it matter? Because the risk of extraglandular features, the risk of extraglandular features, which are the other organs that can be affected in Zika? The most common organ besides the first exocrine gland is the arthritis. It can also cause cirrhosis. Also present as NSIP, mononeuritis multiplex can occur. Acute interstitial nephritis can occur. And it can also present as distal RTA, renal tubular acidosis. Recall the topic we have written. In renal tubular acidosis, 30% can be associated with autoimmune disease. ये आपको कल का टेबल ओपन कर देता हूं. In the patient type 1 RTA, 30% are associated with other autoimmune disease. Most common among them is Zika syndrome. Most common among them is the Zika syndrome, which we are studying now. But what is most common cause of death? Dreaded complication in the Zika syndrome is the lymphoma. Dreaded complication is the lymphoma. So what will happen to the specific antibody SSA, SSB, which is both diagnostic and prognostic? Which is both diagnostic and prognostic is the SSA and the SSB. SSA and the SSB. The treatment given in the majority. The treatment required by the majority will predict the prognosis of the disease. Will predict the prognosis of the disease. We can say predict the prognosis of the disease. Fatafat fill karo. Keep this column ready, then we will write it together. Give me a thumbs up if you have done with the column, then we will start. Come on. So सिक्का सिंड्रोम और अभी तक ठीक चल रहा है. थम्स अप का टाइम आ गया है ना, नींद आने लग गया ना, थम्स अप का टाइम आ गया. चलो पुट सम थम्स अप, लेट्स रिमेन अवेक. थोड़ा सा लास्ट टॉपिक छोटे से रह गए, 2 पेज. So if a middle-aged patient, after confirming exocrine gland involvement, you will do ANA testing, comes positive, look for other autoimmune disease. Other autoimmune disease is present, matlab secondary sikka. No other autoimmune disease is present, matlab primary sikka. This will help me identify prognosis, because it tells me the risk of extraglandular involvement, the risk of lymphoma, the risk of specific antibody titer. The treatment in majority gives me prognosis, gives me the prognosis. Chalo, good, thank you. So what we have here, very good. High risk of primary में सब कुछ रेड है. High risk of extraglandular feature, there is high risk of the lymphoma, there is going to be high titer of specific antibody. The majority will require steroids because organ involvement is there, making the prognosis poor, making the prognosis poor, right? So great. So see, ये सब थोड़ा बीच बीच में आप करते रहेंगे तो माइंड एक्टिव रहता है ना. कम ऑन, वेरी गुड. सो मेरा भी तो माइंड एक्टिव चाहिए यार. दूर बैठा हूं मैं आप लोगों से, सामने होते तो देन देयर वाज नो रिक्वायरमेंट फॉर स्टिमुलस. बट ऐसे कैसे, आई एम ऑल्सो दिस लिटिल अर्ली टू बेड अर्ली टू वेक अप पर्सन. तो क्या रात को 9 o'clock के बाद ना मैं तो ड्राइव भी नहीं करता हूं, बिकॉज नींद आता है मेरे को बहुत. बट चलो कोई बात नहीं, 10:30 तक अपना टारगेट है, उसमें हम लोग कंप्लीट भी करेंगे. So in the primary sikka, luckily it is rare. Luckily it is rare. But when it is present, there is a high risk of other organ involvement. There is a high risk of lymphoma, since it is the disease specific antibody in high titer. Organ involvement is an indication for steroid, making the overall prognosis poor. But if it is secondary sikka, which is common in rheumatology clinic, it is associated with low risk of extraglandular feature. There is no risk of lymphoma. There are low titers of specific antibody. Majority require palliative only, making the prognosis good in majority. Making the prognosis good in the majority. Prognosis is good in the majority. Yes, making prognosis good in the majority. Right? So what will you give for mononeuritis multiplex is steroids. Right? So what is there? Important point is diagnosis and prognosis of Sikka syndrome. Since most of them are secondary in nature, the prognosis of Sikka is good in the majority. इसीलिए ऐड कर दो. हमने क्या कलर दे दिया उसको? ग्रीन कलर. So we have studied the lupus group of disease when ANA is positive. When ANA is positive in rheumatology disease, most likely patient is suffering from lupus disease. Based on the specific feature, specific antibody present, we identified whether it is SLE, In scleroderma, we identified whether it is limited or diffuse. In Sika syndrome, whether it is primary or secondary. That's all. Simple. So coming to next one, group of disease, myositis syndrome. So kitna page reh gaya? Last 2 pages of the day. Last 2 pages of the day. One for myositis syndrome, one for overlap syndrome. Chalo, let's write down. What are the myositis syndromes? So simple chart banana hai, that's all. Nothing much to worry. Myositis syndromes. So these myositis syndromes were typically part of neurology. But they have come to us because there is inflammatory disease. है ना, इसीलिए हमने उसको अडॉप्ट कर लिया. These are inflammatory muscle disorders. These are inflammatory muscle disorders. It is inflammatory muscle disorders. We have got are the myositis syndrome. In the myositis, I have written down the most common classical syndrome. Classical is the polymyositis. Classical syndrome or most common cause of myositis syndrome is the polymyositis. Big column. We have to compare it with dermatomyositis. We have to compare it with dermatomyositis and the atypical. Atypical is what? Atypical is inclusion body myositis. Is the inclusion body myositis, which is rare. Which is rare. Okay, so make the table, we will study then. Right, so what is our simple pattern? From definition to prognosis. Definition to prognosis. That's all. Polymyositis is defined as inflammatory polymyopathy. It is defined as inflammatory polymyopathy. Do the first 2 table together. First 2 table together. Poly and dermatomyositis almost the same except for few addition which we will write. So inflammatory polymyopathy is polymyositis, but if you add the skin manifestation present, it becomes dermatomyositis. Both the disease have common epidemiology. Both the disease have got common epidemiology. Both present in 20 to 30 year female dominant disease. So polymyositis, dermatomyositis, read it together. Both are young age myositis syndrome. Young age myositis syndrome. Dermato only has additional skin feature. What are the associated conditions? What can be associated conditions? Important. The polymyositis can be associated with other autoimmune disease. It can be associated with other autoimmune disease in 30% of the cases, where we will study in the next topic. It is the part of overlap syndrome. So it can be part of rheumatology. Multi-system involvement can occur in 30% of patients. But dermatomyositis along with autoimmune disease, 15 to 30% may be associated with internal malignancy, which is the worrisome. With the internal malignancy can be present. Internal malignancy can be present. So, which malignancy? Hematological or the GI tract malignancy. GI tract malignancy can be associated. So, this is the only myositis syndrome associated with malignancy. Remember, only a myositis syndrome associated with malignancy. What is most common presentation? Most common presentation, they present with painful proximal muscle weakness. Itis है ना, inflammation. Myopathy, proximal more than distal. Muscle weakness is present. Proximal more than muscle distal weakness is present. But important point, extraocular muscle never affected. Extraocular muscles are never affected in polymyositis. What screening test you want to do? The screening test, I can do serum creatine kinase level. CPK, creatine kinase levels are more than 1000, typical of the disease. More than 1000, typical of the disease. But the gold standard in all of them is the muscle biopsy. Gold standard in all of them is the muscle biopsy. And the drug of choice in all of them is the steroid. Inflammatory disease है ना, सब में treatment of choice is steroid. So that is why we have included it under rheumatology. चलो न्यूरोलॉजिस्ट भी क्या याद रखेंगे कि हमने मदद कर दिया उनका. So myositis syndromes are a group of disease, inflammatory muscle disorder. They are a group of disease, inflammatory muscle disorder. They are a group of disease. Polymyositis is most common. Polymyositis is most common. It is defined as inflammatory polymyopathy affecting young female coming with autoimmune disease. They present as painful proximal muscle weakness. Extraocular muscles are never affected. Creatinine is more than 1000. Creatine kinase CPK more than 1000. Biopsy is gold standard. Drug of choice is steroid. Dermatomyositis is same as poly. Same. But what is there additional? There is skin manifestation. It can be seen with autoimmune. It can also occur with malignancy. The only myositis associated with malignancy. Clinical feature is same plus skin manifestation. What is most specific rash? Gottron's rash is the most specific feature of the disease. Gottron's rash is the most specific feature of the disease, which is hyperpigmentation over the knuckles, MCP joint. They can also present with V sign or the shawl sign. V sign or the shawl sign, which is typically a rash over the neck, hyperpigmentation over the neck or the back area. Over the neck or the back area. In both of them, CPK level is more than 1000. Biopsy is confirmatory of disease and drug of choice is steroid. Once you start steroid, response to treatment is excellent response to treatment. In polymyositis, there is excellent response to treatment. In dermatomyositis, there is little less favorable response to treatment. Comparatively little less. But what additional test would you like to do? That depends on the other disease, no? Additional test, I would like to do ANA testing to screen for other autoimmune disease. But still, the treatment remains steroid only. Response is excellent, making the prognosis best among the myositis syndrome. Making the prognosis best among the myositis syndrome. So they present as painful proximal muscle weakness. Please remember, young girl will say she is finding it difficult to get up from sitting position, finding it difficult for combing of hair, overhead abduction, and it is painful. CPK is high, biopsy confirms. You do ANA test also because 30% can be associated with other autoimmune disease. But response to steroid is excellent. Prognosis is best. Dermatomyositis, additional test. I want to do pan endoscopy and I want to do bone marrow study to exclude malignancy. So prognosis I will only give favorable because the risk of malignancy can be very dangerous. Can be present. Okay, can be present. चलो, so आगे चलते रहते हैं. So next column, last column is the inclusion body myositis. So inclusion body myositis is rare in practice, common in MCQ because it is atypical. It is only a focal myositis syndrome affecting elderly males. Focal myositis syndrome affecting early males, affecting the elderly males. There is no associated disease, but the presence of distal more than proximal muscle weakness is characteristic of the disease because it affects the muscles of the forearm and the hand are affected. So in spite of being a myopathy, the distal more than proximal weakness is characteristic. The CPK level may be normal or even low. Biopsy can confirm the disease, but response to steroid is poorer and there are increased adverse drug reaction due to old age. So no other test is done, but the prognosis is the worst. So it is more due to old age. Old age mein steroid has got higher toxicity. That is why we say prognosis is the worst in inclusion body myositis. Worst in the inclusion body myositis. So the defect is atypical, rare in practice, common in MCQ. Rare in practice, common in MCQ. This is what we have. So इसको मैं हटा देता हूँ. So what we have got understood here, simple points, comparative table between myositis syndrome. Comparative table between myositis syndrome. So most commonly you will suspect the patient to have myositis because common causes are which one? Polymyositis, dermatomyositis, which can present in a young female who comes with painful proximal muscle weakness. Both can be associated with autoimmune disease. But in dermato, along with muscle weakness, there is also skin manifestation. And dermato is the only myositis which can be associated with malignancy, which is dangerous. So after giving steroid, you have to perform endoscopy and bone marrow study to exclude the GI and hematological malignancy. Once excluded, prognosis is favorable. Inclusion body myositis, very rare but very atypical. That's why common in MCQ. अलग है, बाकी से अलग है. Elderly male, focal myositis, distal more than proximal weakness, normal or low creatinine kinase, poorer response to steroid with increased side effect of steroid in elderly, making the prognosis worst among myositis syndrome. Making the prognosis worst among myositis syndrome. Right? So which brings us to the last page of today's session, and that is the overlap syndrome. So last page of today's session is the overlap syndrome. We come to the overlap syndrome. We want to study. Chalo, write it down. Overlap syndromes. When to suspect? Overlap syndromes. When to suspect? Overlap syndromes are suspected in a young female, 10 to 20 years, female dominant disease. The cause is idiopathic. Overlap syndromes are suspected in a young female where the cause is idiopathic. But you will suspect the disease suspected when the patient comes with features of the lupus group of disease, with the myositis group of disease, with the arthritis symptom. So patient has got symptoms of multiple disease groups, and it is confirmed on the screening antibody testing. It can be confirmed when the screening antibody of both group is positive. When the screening antibody of both group, lupus and myositis, are ANA positive and RA factor positive, then you confirm overlap syndrome. So overlap is an English word only, suggesting that the clinical features also can be mixed and antibody also can be mixed, leading to the diagnosis overlap syndrome. The treatment of overlap syndrome depends only on one parameter that you must know in exam. It depends only on the type of arthritis. And that will tell you first line of treatment. So this is the bridge between the lupus disease and the arthritis coming tomorrow. So in the first session of rheumatology, we have learned lupus disease, myositis syndrome. When they come with ANA, RA factor both, you call them overlap syndrome. But in the patient of overlap, if the type of arthritis is non-erosive, then I am going to give the diagnosis as SLE, dominant overlap, and start the patient on steroids. But if the patient has erosive arthritis, then I label the patient as RA dominant arthritis, and the first line of treatment becomes DMARDS, disease modifying anti-rheumatoid drug therapy needs to be given. But please remember, the response to treatment is actually favorable. The response to treatment is better than the individual disease. It is better than in the individual disease. So if it is idiopathic SLE, we know prognosis is bad. But in overlap syndrome, response to steroid is actually better. Response to steroid is actually better, making the prognosis also favorable. Making the prognosis also favorable in overlap syndrome. So moral of the story, just because two antibodies are positive does not make the patient serious. It only means he is suffering from an altogether different group of disease only. I cannot put her in lupus, I cannot put her in arthritis. Then I have to put her in a new group, which is overlap syndrome. But only thing you have to see is the type of arthritis and start with the treatment. Response is better, outcome is better. But further evaluation, the further testing is only for research. Only for research only. And in your case, MCQ only. This is useful. Further testing of the overlap syndrome is for research only. And in your case, MCQ only. So what you will test for? What you will say that when the patient has got the specific antibody testing, based on the specific antibody testing. Specific antibody testing. Depending on the specific antibody present, on a specific antibody if present, I will give the name. So in a patient of overlap syndrome, if the patient turns out to be U1 RNP positive, then I am going to give diagnosis as MCTD, mixed connective tissue disorder. So I can check U1 RNP. If it is positive, then I can say patient is having MCTD. If the patient turns out to be anti-CCP positive, also called as ACPA positive, which is most specific antibody for RA. So what is the full form? Anti-CCP is the cyclic citrullinated protein antibody. Cyclic citrullinated protein antibody is present, then RAB patient को है and ANA lupus also, तो बना दो दोनों का मिलन lupus. So when the patient of overlap syndrome comes positive for anti-CCP also, we call them as suffering from lupus. We call them as suffering from lupus. And if no antibody is present, we call them as undifferentiated overlap syndrome. We call them as undifferentiated overlap syndromes. Simple point. We call them as undifferentiated overlap syndrome. That's all. So if no specific antibody, नाम बन गया undifferentiated overlap. But treatment is the same. As I told you, treatment depends on which disease is dominant. Don't have to write it again. I'm just repeating. Treatment depends on which disease is dominant. Disease is dominant. And Amulya, ये लिखा ना हमने, based on what? Based on the type of arthritis. Based on the type of arthritis, हम choose करेंगे which disease is dominant. Accordingly, start the treatment. Accordingly, I will start the treatment. So does not matter whether the name is MCTD or lupus. The treatment depends on which disease is dominant, and that depends on type of arthritis in the MCQ. You can either give steroid or you start the patient on DMARD therapy. But please remember, response is actually better than the individual disease. So don't feel bad for this young girl कि बिचारी को देखो दो बीमारी साथ में है. नहीं, ये कॉम्बो पैक नहीं है, दो बीमारी साथ में नहीं है, ये अलग ही बीमारी है. This is not a combination of two problems. It is a separate group of problem which actually responds better to treatment. Which actually responds better to treatment. So that is our overlap syndrome. So we have taken the first step in the fellowship to rheumatology. We have taken the first step to the fellowship in rheumatology. So what's the plan tomorrow? Tomorrow the plan is 4:30 to 6:30. We will learn about management of arthritis syndrome. And from 7 to 9:30 we will learn about vasculitis syndrome with fibromyalgia. So tomorrow we will start at 4:30 and study first session arthritis syndrome management, then 7 to 9:30 vasculitis with fibromyalgia. DMARDs are disease modifying anti-rheumatoid drugs. Anti-rheumatoid drugs, okay, are the DMARDs. So first line DMARDs होते हैं. First line are the DMARDs. Right, chal. Great. So all is well. End of the day today. Good night everybody. Right? Yes. Anybody, whatever is there, एक बार जरा quickly देख लेते हैं. So Sika syndrome page, once I will show you. So Sika syndrome, we have got here. Sika syndrome page in front of you. Right. So non-MHC restricted action Medvi is that point is what? That every cell in the body contains MHC class antigen. So suppose T cell comes to check my cell कि ये मेरा self है या foreign body है. मेरा सेल क्या करेगा? MHC class 1 दिखाएगा. आधार कार्ड है तो T cell बोलेगा मैं तेरे को कुछ नहीं करूंगा, तू अपना आदमी है. So when the class 2 is there, then monocyte also cannot touch. And if class 3 is there, complement also cannot touch. Right? Complement also cannot touch. But what is happening? Sometimes what happens here, that our own cell can get mutated and turn into cancer. But isko remove karna padega, and that comes only from our NK cell function, because NK cell is not having any restriction of MHC. It can kill any abnormal cell. Right? That's what we want to know. ठीक है? Okay, Madhvi, I hope that is clear. We'll take it forward. Yes. ना ऐसा नहीं है जवाहर कल आपको इजी लगने लगेगा. रूमैट इज वेरी वेरी सिंपल टू प्रैक्टिस एज कंपेयर टू नेफ्रो. मॉर्टेलिटी भी रिलेटिवली कम है, बट फिर भी आई अंडरस्टैंड because nephrology seems more familiar to you, because at least हमने सुना हुआ था. But rheumatology है ना, it's a total different ball game. Rheumatology is such a niche branch of medicine that most people consider it super specialty, and that is why people find rheumatology tough. Rheumatology is not tough, but just that it has to be totally evidence based. There is no yes or no. आना आता है या नहीं आता है, rheumatology में guess नहीं कर सकते, because rheumatology में हर एक का protocol होता है, and that you have to respect and follow. That's all, right? So good night everyone. See you tomorrow 4:30. We will start with our arthritis syndromes. No, Amulya, there is no genetic predisposition per se. We don't know. It's not identified. Right. So we'll call it a day and have a lovely night and see you tomorrow fresh.